Well, good morning. I'm excited today to start our study committee on public health. I know many of us on this committee have served on appropriations. Mickey Chanel also will be as part of this committee, and we've been looking at funding of public health in Georgia the past couple of years. So we are going to begin the process. I've given our members, I guess one of the things that really has sparked this is basically a breakdown of grant and aid allocation per county based on population and what they receive per resident. So today we have a lengthy agenda, I think in honor of Jeff Brown. He worked us to death, that was for sure, on the committee, and so we are looking forward to hearing from the Department of Department of Health. And but first, I'd like to just have the members, if you would, just briefly introduce yourselves and tell us where you're from. Lynn, let me see, what number are you?
My name is Lynn Walker. I'm from Loganville. I represent District 107, which includes a portion of Walton and a portion of
Gwinnett County.
I'm Ron Stevens. I'm District 164, represent Chatham County, Savannah, Richmond Hill, Bryan County, and Liberty County. And I'm Chairman of Economic Development and Tourism.
Good morning. I'm Ed Reigers from House District 152. I have parts of Lee, Doherty, Worth, and Colquitt County in beautiful southwest Georgia.
Okay, thank you. And we're going to begin this morning with Dr. Brown, who's going to give us an overview of the mission of public health. And we will be breaking we'll probably have a little 10-minute break. We'll just see how time goes, but we'll definitely be breaking at noon. So thank you.
Thank you very much. I appreciate the opportunity to talk with you folks today. My remarks are going to be brief, partly because the people who follow me have much more interesting things to say, and partly because I've got a bad cold, which is really nice because I got it from my grandson. So, you know, all things are fair in the world of grandpas and grandsons. I just wanted to start out by talking a little bit in general about the purpose of public health. Our purpose, our guiding spirit really is to improve the health in Georgians. That encompasses really two different pieces of work: trying to protect them from external threats, those things outside them, whether they're environmental issues or whether they're preparedness for emergencies, or whether they're issues around outbreaks, and promoting the health of people. So it's protection and promotion. And promoting the health of people encompasses both improving their health behaviors, which is, I'll show you in a moment, is the major underlying factor driving most health issues. It is a critical area for us to focus on as we move into the new century and look at the challenges that we're facing. Let's see. Technologically challenged, apparently. Yeah, I'll take this somebody who knows what they're doing. Our focus really is on prevention. Prevention in all varieties. Prevention by avoiding the thing ever happening, and prevention by dealing with problems before they get worse. And we have selected what we think is the areas where work is most likely to improve health. I've referred to these already: the safety and protection area, the promotion of health behaviors, and I think a special area that Georgia needs to focus on is birth outcomes. There are two reasons that that's a particularly important thing. First of all, we are among the worst in the states in birth outcomes in terms of infant mortality. And secondly, the United States is among the worst of the developed countries. And so it's a huge problem. The other dilemma is that the babies who are born early, which is the primary cause of infant mortality, The babies who are born early and who survive are very often left with serious lifelong disabilities. And so we're continuing to have these downstream problems, these real serious problems that occur from low birth weight babies. So babies that are born that are less than 5.5 pounds run an enormous risk of both of these adverse outcomes. The other facet of public health work is that we have to be focused on measuring outcomes. We have to track those both locally and at the state level in order to provide feedback on the progress that we're making. Let me just talk a little bit about the prevention structure that I'd like to leave with you a little bit. I think given that major health issues are obesity and heart disease and cardiovascular disease resulting in stroke and myocardial infarction, these are long-term issues that require steady work with very different people than have usually given the vaccines for the prevention of childhood illnesses or that have led to particular antibiotics for an ear infection or other things. And so we have to have very different partnerships in order to tackle these problems. We have to use the data that we develop to identify what those problems are, to target them, and to monitor whether our activities are having a result. And when we're interacting with these diverse partners, we have to make sure that we continually ask, what can you contribute to this effort? How can you help us in this work? Because it's not public health, it's not possible that public health can do this alone. Similarly, the prevention focus really causes us to say, what's the data? How are you defining the priorities? What are the disparities that you're focused on? And I think those are really important issues. Let me just talk a little bit about what's behind health problems and why I'm talking so much about this prevention stuff. We know that the majority cause of poor health are the lifestyles that people select. In part, those lifestyles are individual selection practices, but in part, they're fostered really by the community in which that individual lives and works. For example, those of you who drive around 285 probably have not really gone the speed limit of 55 miles an hour. And if you have, I'd suggest that you were probably a hazard to the other motorists on the roadway. So that although that's an individual behavior, it's really conditioned by the environment in which you are. And so lifestyles accounts for 50%, more than 50% of the underlying causes. And we're really talking here about things like those major chronic illnesses. Healthcare, which consumes an enormous amount of our attention and effort, contributes probably 10% to the health of our citizenry. And our investments have tended not to be on how do we change the environment, how do we alter the factors around a genetic abnormality, but really around the healthcare problem. And so that's the one message that I'd like to leave with you, is a thought that it's really time for us to try to rethink our paradigm about what it is that public health does and how it is that we can have the most effect. It's clear that the resources are insufficient to do everything that might be important and might be useful. And so we have got to get some clarity as we move through this hearing, and that's what I'm going to be trying to contribute to. I'm now going to turn the podium over to the other staff who will give additional perspectives so that you can get some granularity in these general concepts. Thank you.
Dr. Brown, can we get a hard copy of your presentation, please?
Yes.
Okay, thank you. And just to let the members know, I thought it was important for us to, before we ever begin looking at the funding formula, we have to determine exactly what public health is in Georgia, so that's what we'll focus on today. Okay, now we'd like to hear from Dr. Sherry Drinzek. Thank you.
Good morning. It's a pleasure to be here with you this morning. And I and one of my colleagues from the Valdosta South Health District will be talking to you a little bit this morning just to give you a discussion about a salmonella outbreak that we investigated recently in Valdosta, Georgia. Just to start out, just to sort of set the stage, to think about, you hear about disease outbreaks. Well, what do we mean by a disease outbreak? What is a disease outbreak? It really is only more cases or more occurrences of disease than we usually see. But they're linked together in the same time, in the same place. And so we think of them as being linked to a common source. So for us in public health, our job is to find that source. What links these individuals who are sick together? So our role is to conduct an investigation then that really has three main components. We use our public health laboratory, we conduct an epidemiologic investigation, and we conduct an environmental health investigation. And those three critical components come together to again be able to determine the source or the cause of that outbreak and what made people sick. And we do all of this in order to result in some sort of a final control measure, an action item that, again, will stop that outbreak immediately and stop the disease spread, but hopefully also have implications for the broader population, or we learn enough about a given outbreak that it has effect on other individuals' health as well. So this outbreak was a salmonella outbreak. I thought I would just briefly mention, well, what is salmonella and why is it so important? Salmonella is a bacterium that can cause illness in people, can cause diarrhea, nausea, abdominal cramps, and it can result in very severe and even fatal infections, depending on if an individual is immune compromised or very young or very old. We can see this as being a very severe disease, so it's a very important health problem. We see that salmonella can be spread by food. And there are many, many, many different types of salmonella. And we rely upon our disease surveillance mechanisms and our public health laboratory to type these organisms or to, again, fingerprint them. It helps us determine the source. So how did we find out about this outbreak in Valdosta? It was, in fact, due to our public health laboratory, our Georgia Public Health Laboratory. They discovered an increase in Salmonella Montevideo isolates from South Georgia patients, more than they typically see. So again, they were all linked together in time and space, and they all had the same fingerprint. And what I'm showing here on the slide, just to kind of give you a feel for it, is our lab can, using these fingerprinting methods, determine these salmonellas were all the same, they had the same fingerprint, and it indicates to us or suggests that they had the same source. So you put all of these pieces together, and that is equivalent to or is equal to an outbreak. So that, again, launches our public health investigation, as I mentioned earlier, to try to determine that source. So the first piece of the investigation is the epidemiology investigation. And again, what we can equate this to is just looking for patterns, doing a little disease detective work, if you will. And in this case, we're looking for, well, out of all of these individuals that got sick, that all had this same salmonella with the same fingerprint, what unites them? And one of the tools we use, first of all, is to map out cases of people that were sick and look to see whether they were all in the same neighborhood, whether they all shared other possible exposures. And if you look on that map there, you see they're spread out all over generally the Valdosta area. And we interviewed these people to get clues about what their common exposures might be. Did they all eat at the same place? Did they all share a water source or a well? And it became clear once we interviewed all of these 68 people that we found that one possible exposure that kept popping up over and over again is that they indicated that they had eaten at a single restaurant, a single fast food restaurant in Valdosta, an Arby's restaurant, prior to getting sick. So that launched, if you will, our environmental health investigation at the restaurant to try to determine the source of the salmonella in that restaurant. And now I'd like to turn over the presentation briefly to my colleague at the District Health Department, Janine Godfrey, to come and talk a little bit about what we found in that restaurant, and then I'll come back and talk a little bit about the control measures at the end. Janine, thank you.
So upon the environmental investigation, we realized that the Arby's had recently been remodeled and actually had just opened mid-August, and they had several new employees as well as several new pieces of equipment. And one of the new pieces of equipment that they had was a meat slicer used primarily to slice roast beef, but they also used it to slice some of the vegetables. Upon talking with the state epidemiologist, food and environmental samples were taken, and we were specifically looking for salmonella. What we found was that salmonella was on the meat slicer blade, with the same fingerprint as patients, indicating that that was the source of their infection. We then immediately removed the slicer from use, and they did have an old slicer that they had. Of course, the old slicer was not as good as the new slicer, but it was still efficient to be put into service. The restaurant cleaned the slicer, and even the manager, the area manager, cleaned the slicer himself. And after he cleaned the slicer, we still found salmonella under the plastic blade indicated by the arrow. And what we found was that this particular slicer was supposed to have a silicone seal made by the manufacturer that could have possibly prevented the contamination. So upon our investigation, we somewhat concluded, or we did conclude, that roast beef may have been a source of the salmonella on the blade. And it's been, looking at the literature, doing literature reviews, it's been quite a while since roast beef has been implicated as a cause of salmonella. Most of the time we think poultry, we think chicken, we think eggs, but in this instance, it was the raw roast beef. Sherry?
Thanks very much, Janine. I appreciate it. So in this particular outbreak, again, all of this information and the partnerships between our laboratory, the local epidemiologists, the local environmentalists, and the restaurant, again, once we removed that slicer from use, no further cases of salmonella occurred in the community. And again, it also allowed us to not only stop that outbreak immediately, the immediate outbreak that was going on, but we learned that, again, this particular meat slicer has potentially a manufacturing problem, and we are able then to sort of, the ripple effect of this investigation is that, in fact, there will be better quality assurance on this plastic part of that meat slicer so that the manufacturer can ensure that the silicone seal is in place, that, in fact, it will prevent further outbreaks like this from ever occurring in the future, whether it be in Georgia or anywhere else. So you see the ripple effect is quite wide. And we were able to also, one of the other control measures was to be able to educate the employees of this particular restaurant about handling raw meat products, whether it be poultry, whether it be roast beef, and to ensure really when beef was on that slicer, it should have been cooked. They slice cooked roast beef on that slicer. So what ended up happening, we presume, is that perhaps in the because there were new employees and because they were very busy from just opening up again, perhaps it wasn't cooked properly, and then with allowing some raw meat juices perhaps to flow in between that plastic part and offer contamination to other roast beef sandwiches as time had gone on. So our control measures, again, that public health action resulting from determining this source of the outbreak and removing it. As I conclude, I would just like to acknowledge all of our colleagues that worked on this outbreak investigation in order to promote and improve the health of Georgians. Thank you very much.
Yeah, Dr. Dronzak, I have a question.
Sure.
If we can get rid of that buzz.
Yes, yes, we do, absolutely. And again, those areas will be brought up in some of the other presentations and vignettes that you'll see for some of the public health work that is done. Yes, yes. Mm-hmm. Thank you all.
Good morning. We appreciate your efforts, and especially your investment in time to hear our stories. This is I'm going to talk today about the BioLab fire in Conyers, Georgia, that happened, and it occurred on May the 25th and the 26th, 2004. And this was the same time preparations were being made in Brunswick for the G8 summit that was going to be June the 8th through the 10th. A lot of the key players were preparing for this summit, and they were in Brunswick at the time. But it was a good exercise for us in the fact that we proved to be effective in responding due to the redundancy and training that we've had in our districts and at the state level in our emergency preparedness efforts. Let's see. Conyers, Georgia, is 24 miles east of Atlanta. It Interstate 20 bisects city and county. And the Rockdale population is about 76,000, with 11,500 residing in the city of Conyers. And the BioLab facility was very close to the city of Conyers. Rockdale County is 130 square miles and the second smallest county in Georgia. At approximately 4:15 in the morning, an off-duty sheriff's deputy called the Rockdale 911 to report the smoke coming from the BioLab facility. The first responders were on the scene within minutes, and the process began to determine the contents of that warehouse. And they contacted Chemtrek, it's a 24-hour hazmat communication center founded as a public service of the American Chemistry Council in 1971. And the decision was made to fight the fire and flood it with water. At 8:45 a.m., EPA and local officials met and began general and contaminant-specific air monitoring. This shows you a location of where the facility is in conjunction with Interstate 20 and the residential neighborhood over to the right that eventually had to be evacuated. The BioLab warehouse contained approximately 250,000 pounds of solid blocks of chlorine-based chemicals, and which are highly reactive to waters. Firefighters used ladder trucks to spray water on the fires. The smoke plume extended nearly 100 miles downwind from the fire site. I don't think a lot of people knew exactly how large the smoke plume was. Testing was done every 2 hours by the Los Alamos Labs. They have a special plane that provided the testing of the plume to determine the contents of the plume. Initial testing revealed little to no contamination, and then later analysis revealed a shift in the winds and an increase in the harmful chemical levels. And this was a problem because they would have to continually close and open Interstate 20 based on the levels and which way the plume was going. So it was really a chore for the first responders and the police departments in those areas. A voluntary evacuation of 4,600 residents began at 9:30 in the morning, and this included a trailer park and 2 subdivisions where a majority of the residents spoke Spanish. Interpreters were deployed by the health department to assist with the evacuation process. Air monitoring was conducted of the smoke plume by 2 teams due to the size of the plume and the need to find the outer reaches of the plume. During the early morning of May the 26th, air monitoring indicated that chlorine was present at levels near the permissible exposure limit. The limit where it's actually harmful to humans is 3 and is 0.03 points per million, but the highest it ever got was 2 2.8. So we had people that became sick, but they were people with respiratory diseases and things like that. We did have people that became sick. May the 26th, the fire was extinguished and EPA reported no discernible levels present. May the 26th, 2004, at 1500 hours, the District Emergency Operations Center officially stood down. Most of the clinical effects were irritation of airways, eyes, nose, and throat, and irritation of skin. Approximately 79 people were seen in 6 of the 14 emergency departments for these symptoms. State and local press releases were issued in English and Spanish advising of what precautions to take. The district epidemiologists provided ongoing surveillance of all the emergency rooms within the area every 30 minutes to see if any of the illnesses presented were possibly attributed to the chemical, fire, or the smoke. Rockdale Medical actually had to close down and start diverting their admissions to Newton Medical, Gwinnett Medical, and Emory East Side because they were right in the path of the smoke plume. The state epidemiology branch, they provided surveillance of all hospitals in the projected plume area, including a 20-mile buffer zone, and additional hospitals to the north and south of the plume area to which affected people might go. That included LaGrange, Athens, and Macon hospitals. Sheriff Jeff Wigington, who's also the EMA director for Rockdale County, established a joint forward command post at the fire scene, eventually relocated to a quarter-mile from the scene. Mandatory evacuation of residents and businesses within a 1.5-mile radius of the incident occurred, and Interstate 20 was opened and closed intermittently. The number of residents and business workers that were evacuated were 1,400. There were 2 shelters open for evacuees at 2 different schools in Rockdale County. Ron Berger, the chairman of the Rockdale County Board of Health, was on the scene providing support, and the District Emergency Operations Center opened at 7:15 a.m. Public health staff, nursing and administrative, were reported to both shelters by 9 o'clock that morning. They provided health care services at the shelters until the Red Cross arrived. They assisted Red Cross nurses most of the 28 hours during the sheltering operations. And I have to say, the health department staff was on site the whole time that these shelters were open. Assisted staff from a long-term care facility to care for the 84 patients who self-evacuated to the shelter. And they assisted with a variety of other shelter-related functions, providing interpreters. This is just a few pictures of the evacuees in the shelters. And then environmental health, they were deployed to the 2 shelters. They provided food service inspections, assured proper personal hygiene and sanitation, assisted with providing housing for pets of shelter occupants. They cannot be housed in the same areas, and provided public information concerning health effects and actions to take upon returning to home and businesses. Our District Emergency Operations Center, our medical director, Dr. Lloyd Hofer, he activated the District Emergency Operations Center, and what we do in our district, we activate we call it the FAST team. It's Public Health Assessment and Survey Team. They were on the scene at about 7:30, and these are people that are in that area that are deployed to go out and do an assessment and survey of what the situation is and report back to what we call our DHART team, and then that's how we know how to respond to the event. And that's what they did. And then the DHART also participated in scheduled conference calls with all participating federal, state, and local partners. And this is my second event also. Katrina occurred when I was on the DHART team. And what's really amazing are these conference calls, because they're not only local governments, they're state, they're federal. Every level is on there, GEMA, FEMA, EPA. I mean, it's amazing how they all come together in time of crisis and how well it's done and how organized it is. And I think, and DHR is there, Department of Public Health, and the nursing sections, they're all there and willing to help in any way they can. So that's really a tremendous stride that's been made. This is the assisting agencies, some of them, and I don't know, I may have left out some, but I'll let you look over those. It's Department of Health, Department of Human Resources, the district office, Gwinnett, Newton, and Rockdale County Health Departments, the emergency management organizations, the State Environmental Protection Division, Georgia Poison Control, they played a huge part in this event because of the chlorine gases that were created when they put water on the chlorine blocks. The Los Alamos labs providing us the technology and providing us the analysis of the plume, and the U.S. Environmental Protection Agency, DFACS, GEMA, FEMA, Agency for Toxic Substances and Disease Registry. And one thing I'd like to say, there's a few pictures that I also have to show you how huge the actual plume was, but this was definitely a unified agent. And in the past 16 years, the health directors and the emergency, well, we didn't really have emergency preparedness directors in, but we had program managers. But our top levels in our district health offices, they have been building relationships within our communities with the coalitions and others. And after 9/11, those partnerships definitely expanded. I mean, we began partnering with hospitals and veterinarians and medical examiners. And now that the flu epidemic has been discussed, we're now partnering majorly with businesses and people like that, because they're very interested in how we're going to do mass distributions if we have to for pharmaceuticals. So, but the main thing about this is that when you do something, this only lasted 48 hours, but it pretty much drained our resources. We had our health centers were closed because we had to pull all of our staff from Newton and Rockdale. Well, they also had to close because of the smoke plume. It put those sites in danger. So they had to close, but they were pulled into the shelters to work, the nurses and the administrative staff. And what happens is, if it lasts 48 hours, you can handle that because you have enough staff to handle that. But we also had to pull staff from our Gwinnett sites, and you can handle that for 48 hours. And the next rotation, we really don't know if we would have the resources to handle that. But it did, monetarily, it did cost us quite a bit of money, because for Newton and Rockdale, those two centers were shut down completely. Gwinnett services were reduced. So our fees, we didn't provide the services, so we weren't able to collect any fees, and it definitely had an impact on our revenue. So public health is not going to change, I don't think. We are going to be there to respond to natural events and terroristic events if they occur, but it's just important to know that our resources are limited, and that this is just something that we do when it's required, but it does put a drain on us, on our resources, our staff, and that sort of thing. So one thing, just like with the floods in Albany and the Katrina hurricane, that also, we had to schedule and reschedule and do a lot of scheduling with our staff. And we also work with the state, and we work with public health and DHR to provide us with resources that we need, and they do that also. But there's really no budget for that sort of thing. That's all.
Thank you, Ms. Brown. Any questions?
Yes.
Ms.
Ms. Brown, thank you so much. Do you know if there's state guidelines in regards to the warehousing of that kind of chemical relative to hospitals, schools, nursing homes?
You mean the location of the facility next to those sorts of facilities? I don't know.
Usually local fire code, they have to tell local fire chiefs what exact chemicals are in those locations. Typically have to get approval or be told.
I guess, let me rephrase it if I may. If someone, and I'm not a chemist obviously, but if someone wanted to come in and open up a chlorine block distribution center, are there any current guidelines of certain chemical levels, and they can't be located within X amount of miles of a school or anything like that? Is there any of those kind of?
I don't think so, because it was this facility is adjacent to I-20. I mean, a very heavily traveled, and also a residential section. It was very close.
Do we know how many pounds of chlorine blocks would have been needed? And I'm sure weather conditions matter. How many pounds of these blocks would have been needed to reach your 3.0 standard that you got to 2.8 on?
I don't know. I think maybe the main thing was that the fire was put out before it could have reached those levels. But I think 250,000 pounds was probably enough to create those levels. However, I think the fact that they were able to put the fire out fast enough within that short time period that saved people from getting really physically sick.
Do you know if there's any storage facilities, if I may continue, if there's any kind of storage facilities or distribution centers that hold any kind of chemicals that you can't put out with water because it would cause a hazard? That
I don't know, but I certainly could find that out for you if you'd like for me to.
There's lists of what chemicals can be put out with water, and they made a decision to, typically you would not use water on solid chlorine, but they let the fire burn for days. And it was more than just chlorine. The chlorine byproduct was also phosgene gas and cyanide, and they had to fire out to kind of decrease the risk of cyanide getting out in the other hospital.
Thank you.
Let me introduce Joseph. This is Joseph Sternberg. He's our District Environmental Health Director.
Thank you. Definitely appreciate your presentation. I think it definitely mirrors what, I guess, complements what Dr. Brown was saying. You know, the public health absolutely is important for prevention, but also to protect citizens from spills. Right, absolutely. All citizens of Georgia. Thank you so much. And now we'll hear from Lita Ward, RN with Miller County Health Department.
Right, thank you. And that is two separate counties.
Right.
I want to see how we are advancing.
You're going to invite us down for all to see Swamp Gravy for...
You bet. You bet. The Christmas programs are going on right now. Okay, thank you. Thank you. To kind of give you an idea of about Early County and Miller County, Early County has a population of about 12,300, and Miller County, 6,200, thereabout. In our district, we consider those a medium and a small-sized county. And the reason I'm the manager of both is due to budget restraints and trying to fill the needs and fill what had to be done in two counties. What I want to talk about today, though, is public health partnerships. It's not a secret in that corner of the state, and really in the state of Georgia, we have a higher than usual rate of heart disease, stroke, diabetes, and this was something we had to address in our corner of the state. There's a lot of folks just improperly accessing emergency rooms, and a lot of folks without good health care. Back in April of 2000 was the first Rural Health Conference sponsored by the Health Policy Center, and some individuals from early in Miller County went, hospital administrators and public health, and some employees from DFACS, different individuals went. And the bottom line that they were delivered during that meeting was that monies that are going to come down are no longer going to come down to one agency or to one county. That monies are going to come down to networks and collaboratives, and we want to see people working together. So Early and Miller came back, started working on it. Calhoun County joined in very shortly. Calhoun County has a population of about 5,000. 1,000 are in the state prison, so it's really a population of 4,000. So I'm just trying to give you an idea of these small rural counties there in the corner there. Started meeting and planning. How can we improve access for our folks? How can we have a healthier population? And public health was there. We provided facilitators, we provided epidemiologists, data, and most importantly, leadership process. Because you have to remember, this football team in this county beat this football team in this county last year, and there's still some bad feelings. So a facilitator was very important, and public health was really great in providing that. Our partnership yielded some great realities. About 2002, we titled our cooperative the Spring Creek Health Cooperative. Spring Creek is actually a creek that meanders through those three initial counties. The original mission statement was to decrease the incidence of stroke and heart attack in southwest Georgia and decrease the inappropriate use of the health care system. I don't think it's a secret to any of you what our emergency rooms costs are to the taxpayer every day, that they're being abused and used improperly. Today, Spring Creek Health Cooperative is a nonprofit healthcare network providing prescription assistance and or behavioral case management to over 2,000 residents of 8 counties in southwest Georgia. Those counties are Early, Miller, Calhoun, and Clay, Mitchell, Grady, Thomas, and Brooks. And I brought you to this point in a hurry, but I do want you to know there were grants written, there were grants awarded, there were grants denied. there was a lot of meeting and trying to plan what would be best to get to this point, but we're very proud to be here. And we have, in the past, when people would come to the emergency, to public health, we are right next to the hospital, and they had a problem, and I could not address it through my protocol. I knew they needed intervention right away. And I'd say, go see your doctor. And they would say, I can't. I owe too much. Or I have no insurance. I can't go. I sent them to ER. Inappropriate, wrong, yes, but it was the only choice I had at that time. Having Spring Creek Health Cooperative in place in Early County paved the way for us to apply for a federally qualified health center in Early County, and we opened in March 2006. At this time, I'm going to turn it over to Kevin Taylor. He is our partner in health care. He's with Vice President of Archbold Affiliates, and I'll let Kevin take it from here.
Thanks, Alita. I too want to thank you all for hearing me today and talking about the partnership that we're here about. Again, my name is Kevin Taylor, and I work with Archbold Memorial Hospital in Thomasville and our affiliate hospitals. What I really wanted to come up here today and say is that we're about collaboration. We do have an ulterior motive. We were a hospital, and we recognized that the cost the burden of the cost in the emergency room is just something that is spiraling out of control. And we recognized that we needed to invest in a cheaper way to keep these folks healthy and what we needed to do. And this partnership that Alita has described really was an effort to reduce inappropriate emergency room utilization. And the process that we went through is pretty unique to this area. And again, it's all about collaboration. We wanted to decrease our inappropriate ER utilization. We wanted to increase access to care. And what the hospital, with the partnership with Public Health, did was we invested in this process. And I keep saying process for a reason. It took a long time to get to where we are, to get to the New Start Community Health Center, and to actually have a place where there is increased access that's not an emergency room, and ultimately a cheaper place for these folks to get health care. The important thing also that I want to say is that we couldn't have done this alone. We needed the leadership. We recognized that it couldn't be done just on the hospital. We recognized the benefit of what Public Health does do every single day, and that we didn't need to duplicate resources. So we have been working together for the last couple of years, and to a little bit more expound on some of those things that you don't really think about. In the 14 counties in our area, there's a population of 355,000 people. Of those 355,000 people, there were 178,000 visits that the health department provided. We obviously know what we take care of in the emergency room, and some 45% of those people are self-pay in our emergency rooms. If you look at what the health department does, 50% of those folks are self-pay, no pay. So what the health department was doing also does not need to go away. A lot of those folks would not have received the care that they currently receive through the health department. So we realized that there needs to be a partnership and a collaboration to get us where we're going. And then, of course, the beauty of what Spring Creek does to provide the pharmaceutical assistance and the case management for these folks who just tend to not take care of themselves and inappropriately abuse the ER. So glad to be up here today to tell you that what we think we've put together down in Southwest Georgia is a little bit unique, and it is working for us. And again, I don't personally feel it would have happened without the health department's leadership. So thanks.
Thank you so much.
If I may,
We have a question.
If I may, just for the benefit of the other members on the committee, the region that he represents, all of it lies in the 2nd Congressional District. It is the 9th Congressional District in the United States. The Medicaid dollars in Georgia are about 19 cents on every dollar. In the 2nd Congressional District of Georgia, it runs close to 40% of every medical dollar is a Medicaid dollar. So very high poverty and indigent rate, and that puts a tremendous amount of pressure on the public health systems out there.
Thank you. Yeah,
Thank you.
We have one more question.
Kevin, I think what you're doing is a tremendous idea, and one that I think should be expanded across, particularly rural Georgia, where access is a problem, and the health center is an excellent place for that. Again, tell me, on the ground, how does that work? I mean, how do you get somebody who shows up in the ER that's inappropriate? I say inappropriately, I got a cold or this and that, the other, that service is available regardless of the ability to pay. How do you get them?
Well, obviously, when they show up in the emergency room today, we got to take care of them. Mentality dictates that. So we take care of them today. But what we do is we train the staff to be able to make a referral. So that emergency room staff is able to put some information in that patient's hand, and hopefully the patient will call. Well, we really can't rely on the patient to call. So what we've also done is protecting HIPAA and the patient's privacy. There's actually reports generated biweekly, and we disseminate these reports to the case manager so we can say in real time, so-and-so showed up in the emergency room inappropriately, self-pay patient, and we will have our case manager then go and contact that person. So it truly is kind of a real-time thing where you have to take care of them that day, but ultimately we're going to go and seek that person out and see if they will participate in the programs that are available for them. Find out if they're eligible for Medicaid or what else might be out there for them, the pharmaceutical assistance. And unfortunately, you can't rely on that patient to do these things themselves. Why does the hospital support this? It's going to ultimately save us money. I mean, we're saving hundreds of thousands of dollars in a little hospital like Early Memorial. And that means a lot to us when the margins are thin or there is no margin. So it's an investment. It's a little bit of a unique way to go about trying to save money in a hospital. And it's working for us. So. Thank you all.
Thank you.
I want to thank y'all so much for wanting to hear our story, because I know you have the task of looking at your grant and aid formulas, and I just want to thank you so much for wanting to hear what we're about. Some things I would like for you to consider. Collaborations do work, as evidenced by what Kevin and I have just presented to you. Collaborating is hard work and does not occur overnight. It takes a lot of running into brick walls, backing up, let's try this, well, let's try that, let's see how it should work. And as public health is doing these type of collaborating efforts, it is not funded. Our population-based activities at present are not funded. Another struggle I have is in ensuring these. I know long-range planning is best. I know it's better to keep someone well than it is to try to make them well later. I know prevention works. Prevention is worth an ounce of cure. That's ancient. We all know that. My struggle is I am a clinical public health nurse. I can do every program in that building. I am skilled and licensed by the state of Georgia to do every bit of it, and I can bill and generate revenue and provide services. I can do that within that 1 hour time, or I can attend that collaborating meeting that is so important for long-range planning and for the successes we've recognized with Spring Creek. So you see the struggle we deal with, that not every county public health can just go duplicate this because of limited nurse resources or limited staff to do that. Another thing, some things I'd like for you to know, that while we were working on these projects, getting the Community Health Center going, getting Spring Creek going, at Public Health we were still planning and preparing for our strategic national stockpile. And I know you all know about that, getting that ready, having drills, having used our manpower to do drills, planning and preparing for pandemic flu. I had a meeting just yesterday. And you know, you think pulling a meeting together is easy, but let me tell you something I've learned from medium county to a very small county. The smaller the county, the more difficult. I would not have known it until I lived it. The smaller county, my EMA is also my EMS, is also an LPN. My fire chief in the small county is also, they're not bivocational, they're trivocational, because the little counties have limited resources. In your large counties, they have one person paid position. They can go to that meeting during the day to plan. So we end up doing our meetings at night when people are then having to pull overtime to go to those planning meetings, because these little counties have to prepare just as well. So just to give you an idea that the struggles are very different from a small county to medium to large, and the large counties have their own dynamics as well. In Early County, we're located there on the Chattahoochee River, and we participate in the FEMA and GEMA graded nuclear plant drill activities 2 or 3 days out of the year. We also provide tuberculosis testing, tracking, and treatment. And I can tell you that's a lot of work, and I think Dr. Carson is going to allude to that more. It involves a lot of staff time, a lot of foot on the pavement work. We also shelter evacuees. Thank goodness this was not a hurricane year, but weren't we ready? We all knew it was going to be. But last year, we had nurses that we were having to put into shelters to keep the shelters running, because American Red Cross promises, but they don't have the staff to have there. We have to have nurses there. So my challenge is, in one of my counties, I have one RN. Do I put her in the shelter, which I have to have, or do I have her at the health department doing mandated, by grant and aid, clinical services that are mandated, or do I do shelter work? And that's what we have to, that's the challenge we have in public health every day. Also, about 2 years ago, the governor put out the mandated school attendance task force policy. It mandates public health as part of that collaborative, and we work on that. And we've seen results in Early County, I'm proud to say. Participating in mandated child fatality review committees. And last but not least, while all this is going on, and all this long-range planning with Spring Creek, let's get a community health center, let's do all these disaster preparedness, we provided over 8,000 clinical services that we had to provide, and additional environmental health services. So we keep rolling along. Sometimes we feel like we're, split, trying to serve two masters at one time, but it is a great challenge. In summary, while partnering and a lot of hard work have yielded improved access to health care for our folks in Southwest Georgia, public health continuously faces the challenges of preventing disease, injury, and disability, promoting health and well-being, and preparing for disasters.
Thank you so much, and I do commend you for your collaboration. I think that's definitely the way, the direction of the state. So,
to answer your question on the numbers, of the 184 people in just one county early that were being case managed, there were 225 ER visits the previous year by the same 184 people. The following year, after getting case management and pharmaceutical assistance, there were 42 emergency room visits, and we extrapolate that to be in actual cost, meaning dollars out the door, about $140,000 in savings. And then if you look at the benefit of the pharmaceuticals that they receive, that's over $1 million. But the dollars saved was about $140,000 for those 184 people.
Thank you. Alita, I do have one question for you. Do you have the SHAP program in place in the stroke heart attack prevention program?
We do.
How many patients do you have?
About 152, my last count.
Okay.
And that is 3,000 in the entire district.
3,000 in the district. Okay. Thank you.
And may I speak on that for just a moment?
Yes.
The Spring Creek Health Cooperative is not clinical case management. It is behavioral case management, and it is prescription assistance. In SHAP, we provide clinical case management. We draw lab, we take off shoes, we look at toes, we do education, and we provide the medication. Our formulary is very limited. So when we partner with Spring Creek in a huge way. When we have that patient that has a list of 10 drugs, we'll do what we can through public health. They'll get their labs with us. Then we partner with Spring Creek to go to the house and see what kind of sugar they're eating at night, to get deeper into what's going on and to help them with those other prescriptions. So it really is a very good partnering.
And you said there are 3,000 patients in the district. How many counties?
That's 14 counties, and I believe we are the largest in the state on our enrollment.
Okay. Thank you so much. Well, we're going to take a 10-minute break, and we'll be right back. Thanks. I think we're ready to begin our second half of the meeting. We will be breaking at noon, and I think kind of the focus of this second half will also be to show the collaborations in the community and other things that are being where we do have access, improving access to care in Georgia. So we'll begin with Richard Ward with American Academy of Pediatrics. I saw him in here a minute ago. There you are. Okay, great. You moved.
Actually, Ben's going to start. I'm going to follow up.
All right, great. Thank you.
Good morning. My name is Ben Sloat, and I am with the immunization program over at the Georgia Division of Public Health. And I'm kind of a last-minute fill-in. The immunization program manager was not able to be here, and the next person who was to be here had her father-in-law passed away. So I'm just filling in. And while we were at break, this graph was passed around. I don't know if you all have a copy of it in front of you. But to give you a little background about immunizations in Georgia, in the past, the majority of immunizations were delivered in the public health setting or the public health clinics. And then in the 90s, we started to see a transition where an increasing amount of childhood immunizations were being delivered in the private sector, and fewer immunizations were being delivered in the public sector. So we knew we needed to start to partner with the private providers and pediatricians in order to maintain and achieve high childhood immunization rates. And you can see from the graph that by 2005, about 88% of childhood immunizations are delivered in the private providers' offices, and only about 12% are now delivered in the public health clinics. But Georgia ranks third in the nation, according to the CDC, for childhood immunization delivery for children 2 years age and or around 2 years old. So we're third. We're great. So one of the strongest partnerships we have is with the American Academy of Pediatrics, and Rick's going to talk about our strong partnership with AAP.
Thank you, Ben. Thank you, Madam Chairman, members of the committee. As mentioned, I'm Rick Ward. I'm with the Georgia chapter of the American Academy of Pediatrics. That's essentially the State Association of Pediatricians. We represent 1,700 members, pediatricians either practicing in general pediatrics, providing primary care to kids, or pediatric specialists such as pediatric cardiologists, pediatric orthopedists, neonatologists, etc. I want to go ahead and just focus on a few things and basically say amen to what Ben had said. I think more so than any other medical specialty, perhaps, pediatricians work closely with public health because so much of public health's emphasis, as Dr. Brown mentioned, was on prevention, and therefore, particularly, it affects children. And I think public health has traditionally taken a big, considerable portion of their resources to this broader goal of ensuring the health and safety of children. And obviously, that's what brings them around into our world. I want to say a couple of things at the outset. Number one is that before, again, Dr. Brown mentioned some of the child health markers in Georgia. And every year, a foundation called the Annie Casey Foundation releases Kids Count data. And they analyze 10 indicators of child health and safety in every state across the country. And they produce this report card. Some of you may have seen it. And traditionally, Georgia ranks something like 45th to 43rd. We've bumped up a little bit. There are things like infant mortality, percent of low birth weight babies, teen dropouts, suicides, child death, those kinds of things. And so there's lots to wring our hands about in Georgia in terms of our child health markers. But I tell you, the one shining star that we have among that array of data is our immunization rates. We rank third in the country currently, according to the CDC, and that's one area where we've really shined. And when we go to national meetings and we talk about Georgia, Georgia's recognized as one of the leaders in the country in childhood immunization policy and our coverage rates. And we think part of that is, we'll take some credit, is to the unique partnership and the way that we've worked closely with public health and vice versa to achieve that rate. And obviously the benefits of child immunization are pretty transparent, but to reduce the incidence of vaccine-preventable diseases, they produce a positive impact on the community by reducing parent time off to care for a sick child. They reduce the complications and the hospitalizations and the association morbidity of these childhood diseases, and even in some cases mortality. And they, by keeping children healthier, obviously reduce the impact overall to the healthcare system, whether that's on the Medicaid tab or whether that's even in private insurers tab, which ultimately I think affects all of us. So we think we've got plenty to be proud of in this one particular arena due to the close collaboration that we've had with public health. And I was trying to think of the analogy about that. It might be, a sports one came to my mind, maybe Madam Chairman. I know the guys are probably sports fan, and perhaps Madam Chairman is as well, but if you think of a football team and the coach is in the press box and a coordinator with headphones on calling the plays, well, they can't really do the running and the tackling and catch the pass or throw the pass, but they're going to go ahead and see the big picture, and they're sort of the eye in the sky, and they relay that message down to the field, and that's where it's executed. And in some ways, in a crude analogy, is that's maybe the relationship with public health and pediatricians on childhood immunizations, is that public health pulls back and takes the big picture. They have the public duty charged by you to ensure the health and safety of these children, to develop a system in which vaccine can get into kids' arms and keep them safe. And it's pediatricians and other physicians and nurses and other healthcare workers that actually do the work on the ground, so to speak. And it's that coordination that we think is so valuable. I think there's one thing that's worth pointing out. As a general rule, ideally, we don't see public health as the ideal provider of a direct service for children's health. Ideally, every child should have what we call a medical home. And that's the chart that Ben passed out. When that concept was devised by the American Academy of Pediatrics about in the early 90s, it was sort of a euphemism to characterize what we felt like was important about health care for children, is that it ought to be received from one place, that there ought to be a physician at the center of it to provide the child sick care, their well care, their immunizations, be in the loop on their emergency care, be in the loop on their specialty care, be in the loop if they have a chronic disease that needs to be managed over time. That's your medical home. And my guess is that everybody in this room also has a medical home. Either you use an internist or a family physician, or women might use an OB/GYN, but you don't go 4 or 5 different places for your care. You might see specialists, but your primary care physician, ideally, is going to be sort of the quarterback of that situation. And so in public health departments, when we began to preach the gospel in the early 90s of the medical home, that's when we began to pull immunizations back into the pediatrician's office, to the physician's office, and out of the public health departments, because it made sense to do so, frankly. And public health, to their credit, recognized that and sort of cooperated with the transition. Now, there is an exception, and that is that in some places there simply isn't physician capacity to deliver all the direct service. And so you are going to see public health departments provide that safety net to provide vaccinations, for example, or health checks, or some other episodes of direct service where there isn't adequate physician capacity in a private community to do so. And we recognize that. And that's sort of on a community-by-community basis. But as a general rule, we want the child to develop a relationship with a physician as their medical home. And public health has been helpful in doing that. The other role that public health has is sort of assurance-ish, to provide assurance to the whole system, an adequate supply, to do the counting, who gets it. We established an immunization registry, you did, the General Assembly, about 10 years ago, which has been very helpful in monitoring the overall vaccinations in the system and helping us to monitor where we have particular problems or underinsured populations. In the rare instances where we do have an outbreak, it gives public health, again, maybe the coach up in the press box, the long view of it, more data to analyze and how to move in and intervene and help solve the problem. So that's a very important role, too. And obviously, they have responsibility for maintaining the, I'll call it the infrastructure of the system. They provide the policy, the rules and regulations enacted by the General Assembly that has required vaccines for school entry, for daycare entry, etc. And they're the implementer and sort of the regulator in this area. So it's been a partnership that has worked very successfully. And, you know, the other part I think that is worth mentioning is that we've taken some public policy steps with the leadership of public health here in Georgia that gives us this leadership position in the nation. For example, in our Vaccines for Children program, that's the federal program, VFC, Vaccines for Children, whereby Uncle Sam actually provides probably 90 or 95%. I don't know, have the exact data. But of all the money that we spend in Georgia for childhood vaccines, the state pays like that of it. Uncle Sam picks up the tab, and that's in recognition of the Vaccines for Children Act, which was passed perhaps 15 years ago, that this was such a relatively cheap, so fundamentally sound preventive measure that we would be stupid not to underwrite this and make this part of a core coverage for children, that every child in the nation could get it. If you have you have health insurance that covers it, obviously you don't qualify for the Vaccines for Children program. But many other children do. And so we wanted to be able to say there's no reason in the world for a child, no matter where they live, to get that coverage. But one of the things that Georgia has done is taken the additional step, and we provide VFC coverage for kids who are what is termed underinsured. And that's federal government jargon for you have health insurance, but your health insurance doesn't cover immunizations. Now, as stunning as that may be to you, to think that you would have a family policy and you would insure your children, and then your health insurance coverage doesn't cover vaccines, well, it happens. But VFC is their safety net, and that's thanks to far-sighted policy by public health in the state to extend that coverage, and that also is another factor for our high immunization rates. And while we're on that subject, you'll be hearing at this session we've added another vaccine to the arsenal for cervical cancer. It's called Gardasil, and that will be coming down the pike. And that's I tell you, there's lots to be concerned about and lots that we worry about in healthcare in Georgia or in the nation for that matter. But here's some good news: we've never ever had anything that would stop cancer, that would prevent cancer. This is the first. And we think that would be a great addition to the arsenal in terms of what we provide, initially girls in this case, for that lifelong protection. But anyway, I'll just sum it up by saying that we've had an excellent partnership. Each knows their role. We can't do it. We each have some expertise, but together the complementary expertise has proved real dynamite for the state and given us this leadership position. So thank you.
Thank you. Any questions? Okay. Mr. Chairman.
Thank you, Madam Chairman. Can you comment a little bit? You said that Georgia ranked 43rd to 45th as a healthcare market for children. Where were we before Peach Care for Kids?
Well, did you say healthcare market? On healthcare markers. Markers. Before Peach Care? I'm just guessing, but I mean, at one time when I began to look at the Annie Casey data, which has been published 20, 25 years now, we started almost at the rock bottom, believe it or not. I mean, we had Mississippi or Alabama, or the states that we traditionally trump easily on other markers. We had some of those states in front of us. And I think we might have started, I want to say 48th, maybe 47th. And we've inched up a little bit into the 43rd, 42nd. I'll pull that data out for you, but we've made some progress. We've made some progress in infant mortality and low birth weight babies, but not enough.
Any other questions? Thank you.
Thank you, Madam Chair.
Now we'd like to hear from Margaret Turner, the Heart of Georgia Health to start.
Well, good morning. I am really happy to be here because I'm always excited to share our story. And you've been given already our blue packet, and I just invite you to open it up right now. And the pictures on the left-hand side are real pictures of some of the clients that we serve, also some of the activities that we do. On the right side of your packet is going to be a fact sheet and a couple of annual reports from 2006, 2005, and also a 10-year report from the work that our coalition had done as a grassroots. Begin with the story. I moved to Georgia 16 years ago in August of, I think it was 1990. In 1991, I joined the public health system in the South Central Health District as a breastfeeding coordinator for our health district. It was just one piece there. But I was attending a March of Dimes conference or workshop or meeting at our local hospital. And this was early on in my position there. And I felt like I had been literally slugged against the wall because what I heard was devastating. I found out that Georgia had the highest infant mortality rates in the country. And not only that the South Central Health District, where I was now living, had the highest infant mortality rates in the state. And at that moment, I thought, what have I moved into and why? What is going on here? And that started a work within our public health system to help trying to figure out what in the world is going on here and how can we make things better. As a result of that meeting, in 1993, we decided to form a grassroots coalition. And this was composed of only 7 people. We had a hospital nurse manager from one of our rural areas, and I'll mention that we cover 10 counties in central Georgia, and they include Bleckley, Dodge, Johnson, Lawrence, Montgomery, Pulaski, Wheeler, and Wilcox, and Telfair, and Treutlen counties. And even though we're a small populated health district, 145 to 150,000 people, we serve a very large geographical area. So to get from point A in our district to maybe the bottom part of our district, we may have an hour and 15-minute drive to an hour and 30 minutes. Likewise, some of our clients have to travel sometimes 50 miles to even reach a medical facility that they need to go to for specialized care. Coalition was formed, and this included some health educators, public health personnel, and also a few private people in the community to start looking at just health barriers in our community. We conducted a needs assessment in 1994. And what came out of that, we found out that we had some transportation barriers. And that makes sense because when you're in a rural area, you do not have massive transit. We found out that people could not access health care adequately. We also found out that when moms were going to work, if they were told to practice health behaviors, since we were specifically doing breastfeeding at that time, how could they even do that? Other pieces was that they needed support. They needed that hand-holding support. When you go back to the 1940s during World War II, women entered the workforce for the first time in mass droves. And this left a lack of supportive system in the home-based field so that women did not have that home base. You can probably remember as children yourself, your mothers maybe having teas or coffees and grandma sitting on front porches where they could discuss issues that were relative to health care and pregnancy and raising children. That does not exist too much in our society anymore, and people are so diversified and dispersed, it's hard for them to get health information. We needed to address that, and we started working on just some fundraising projects. I mean, we did bake sales, raffles, garage sales, just to even get money to do media campaigns. We incorporated our coalition in 1996 as a nonprofit 501c3, and we were accepted as a member agency of United Way. This was a big jump start for us, just to get out more into the community and invite more people to the table. We started doing more and more work internally with our health educators and our nurses to try to get the messages out, working with our hospitals. In 1997, we partnered with the South Central Health District, came together at several meetings to say, gee, we've heard about this big initiative, Healthy Start Initiative, which is an infant mortality reduction program. How could we implement this into our South Central Health District to address this high infant mortality and make it work? It was to be a supplemental process with this. We hired additional nurses that could do perinatal case management and specifically see our higher risk clients. We hired peer counselors, and these would be people that would do outreach, that would go knocking on doors, working in housing authorities. They were based in schools, based in working with our family connections, in our hospitals, and also all 10 of our health departments. And we hired people in that area from the community that we were serving because they knew the problems. Several of them were even part of, facing some of the problems and issues. They brought a lot of wisdom to the table. So the consumer piece of this was very, very important because if you do not get the input from the people that you are trying to serve and understand the true reason of the problems that they have, it's very, very hard to even be able to deal with that. We restructured our coalition to become a broad-based consortium instead of just with a focus on breastfeeding. And as a result of that, we now have 11 committees, and they include advocacy, publicity, Breastfeeding is Now committee. We have a collaborative development membership committee, community resources, consumer recruitment, sustainability, teen youth issues, SIDS infant well-being, tobacco prevention, smoking cessation, women's health, men to men. I will tell you how the Women's Health Committee came about to be. And our women's health coordinator in our district said that she needed an advisory group, that's part of the work that she was doing. We already had people at the table instead of being redundant, because when you're in small areas and key leaders, they're at every single meeting, and they can get spread so thin. So we're able to implement this into one larger coalition and just work together with this. In 2001, we competed successfully for the Phase 3 of the Healthy Start Initiative, and I want to talk to you a little bit about what Healthy Start is. Healthy Start is a community-driven approach to addressing infant mortality. That is probably one of the best things about this, because if you're a rural site, you have different needs of what an urban area does. And Healthy Start allowed us to look at our community specifically and design a program that might work, in your area. We have done this by having a case management program, and when I say case management, it's intensive. We work closely with our nurses that were already in the health department, and our nurses are now public health nurses in our health district. But yet we have a referral source. So if we have someone that's doing maybe seeing some high-risk clients, perhaps that person needs a little more intervention, more intensive case management. And this is what we do well, because we're able to do a lot of home visits. Research has shown that when you have a lot of communication, you start breaking down barriers, because in order to be able to really build a trust relationship with the client that you're serving, you have to be there and be a supporter to them. This does not mean just one telephone call, hey, how's it going today? Are you making your doctor appointments? Are you doing that? This is us being able to document whether or not these appointments have been made, whether or not they've gotten their immunizations, whether or not they've gotten X amount of even education that talks about SIDS risk reduction, breastfeeding, nutrition, how to take care of your baby, the importance of getting your prenatal care. We make sure that every mom has a medical home. A concern that I have right now is now that our public health system has been depleted somewhat of our perinatal case management abilities, how that's going to impact us now and even doing even more of this intensive case management. I am curious as to what the outcome of that is going to be, and I'm a little bit concerned about that too. We have a health education program with that. We work with our health educators. The infrastructure that we have in our district, because of being part of public health, is just dynamite. I don't even think I can even convey to you the importance of this. When we do strategic planning, in our district about every 2 to 3 years that addresses perinatal case management. We are also part of a regional team and also the statewide team. Every Healthy Start site in the country is mandated to be linked to Title V agencies, which in our area is, in the state of Georgia, our Family Health Branch. We have very active participation from the state on this. They attend our coalition meetings on a fairly regular basis. We attend meetings where they are doing strategic planning. I call it a domino effect. So if the state is looking at performance measures that need to be met, how can they divvy that down the system? Okay? We're there where we can do that. Public health is a good way to bring that in because we are experts at giving out information. We work closely with our physicians, our hospitals, health departments. As I mentioned, we have staff that work in the school system so that they can work with our teen moms. Partnerships are huge. We now have over 90 members on our coalition, and we have reduced our infant mortality in our health district to below or at the state average level, which is tremendous. We've had a 37% reduction in infant mortality, and I think that is phenomenal. And we have a lot of work to do, and I'm just thankful that I'm able to be part of this system and that I realize the importance of the infrastructure, and I just want to emphasize that infrastructure being in place to be able to continue the work that we do, and that is through our public health system.
Thank you. You have a question?
Thank you, Madam. I commend you for the work that you do. My question to you is that, well, first of all, in the area that I represent, I represent 4 counties and rural counties, and now none, as of a couple of weeks ago, now none of the 4 counties have a hospital that delivers babies. Counting contiguous counties that I don't represent, but is in that area of Georgia, some 6 or 7 counties now don't have, they're just not in the business of delivering babies anymore for financial reasons, obviously, in rural rural Georgia and the reimbursement rates as it relates to delivering babies. That means my constituents and others in that area are going to have to travel a minimum 45 minutes one way to get prenatal care and other things, and up to an hour and a half, so to speak. My question to you is, do you see, is that just my district, or is that, do you see in the area that you represent hospitals getting out of the baby business, so to speak, and if so, what can we do? I mean, it sounds like what you all are doing is right on top of what needs to be done, but how are we going to deal with that? I mean,
I'm glad you asked that, because
we're about to have some $1 million babies.
It's a grave question. One thing with perinatal case management, and when you're talking about not having the services, one of the things that are taught through that program is how to recognize the signs of labor, how to know if your body's changing, and how to be prepared. And that's a problem, because if a woman does not recognize that, gee, what's happening right now could be labor, then she's going to end up somewhere too soon without provisions there. And by having, I guess, educators that can see people on a regular basis, because in our health departments, our clients come in for WIC, if they were coming in for the PCM, also the pregnancy-related services, which was the home visitation afterwards, just to continue the continuity of care, they are taught these things. They go to childbirth classes. We can teach childbirth education. And, we cannot bring in the physicians or the hospitals or the doctors. What we can do is help prevent occurrences from happening when someone gets into trouble, so that they can recognize. Behaviors, being able to do prevention is so important, because we have to educate our population about a lot of, poor health behaviors and how to make changes. Folic acid was one thing that public health did real well. When I first started working, we had 3 babies that were born without brain stems, or born with just a brain stem, almost just right in a row, and I thought, gee, is it the factories here? Is it the air, they're breathing? Is it the fertilizer out here? I mean, these are serious thoughts of mine. I was wishing I was an epidemiologist or something that could, track that. And what we found out is that by the implementation of folic acid, that helped prevent a lot of neural tube defects. And so we've seen a decrease in that. But that's information that is given out through the health departments on a routine basis. SIDS risk reduction, putting your babies on your back to sleep, is a proven measure to help prevent infant death. We are training all of our child care providers in our health district. Our SIDS Infant Wellbeing Committee has all been certified as trainers, where they are teaching every single daycare provider in our 10 counties the benefit of keeping that baby on their back to sleep when they go back into child care, because research has shown that if mom has been instructed to do that, and then they take the baby back to the daycare provider and they put the baby on their tummy, that baby is at much greater risk for SIDS. They're just pieces of information that the general public does not know, and that we have an avenue to be able to get this out.
Madam Chairman, one follow-up. Focusing on prenatal care.
Pardon me?
Focusing on prenatal care. Question to you is that if Medicaid patients and everybody else for that matter has to go, an hour away and that kind of thing, but particularly as it relates to the Medicaid population, that provides transportation challenges and all kinds of different things. And it just seems to me that what's going to follow is not as much prenatal care as is necessary, because you can't meet with a physician in your district, if there's not a physician who can live with babies in your district. And so, what are we going to do about that? And in terms of access to prenatal care in rural Georgia with the decline in the places that deliver babies?
Well, what would draw a physician back to a rural area to agree to birth babies in that area?
Well, I mean, the issue is not necessarily the physician. Certainly, that's part of it. But they got to have a hospital that does it. And the hospitals aren't in that business.
One of the things we're trying to do, and there again with the Medicaid costs, we're trying to. We also are making sure that our clients that they know who their primary care provider is. We had some problems with clients not even being accepted into Medicaid through this change, or not being seen by some of their providers because they said they weren't taking Medicaid anymore. And we even had an infant death that was even a question of that. And we've got to make sure that there is some place for them to go and that they don't end up in the emergency rooms. As far as hospitals go, that is a concern when we're utilizing the ERs for primary care, as this group over here spoke about. I don't know what the answer is for that, except for just, making it accessible in the hospitals as far as the money-wise, that our clients aren't beating the system to death to begin with, but part of them being able to change some of that is just through the prevention piece of that and educating and knowledge.
Well, thank you so much, Ms.
We
Lara.
have addressed that in our county. We came up with a good solution. Do you want to hear?
I don't know what the committee does. I certainly do, and if we do it afterwards.
Yeah, can you do it after lunch? Are you going to be here after lunch? Okay, if you could do that, would be great, because we've got one more presenter, and definitely appreciate what you're doing with Health Start. And I'd like to know how many of these are there others in the state, Dr. Stewart, that have this program in place?
There are 3 other ones in the state besides the one that's affiliated with our local public health department, and those others are not affiliated with public health.
Okay. Could you get me the locations of those? Do you know where they are? I appreciate that. Thank you.
And if I may, why don't they have them in the other parts of the state? And do you take data and compare them from region to one region to see if there's perhaps in that region there's 37%, I think the figure was, decrease in infant mortality rate compared with another regions that's sitting at hypothetically 22%, so you can see what works or what doesn't. But you collect that kind of data?
We collect data on a number of things in public health. You were asking why there weren't other Healthy Start programs across the state?
Right. And do you compare the regions with each other? See what models work?
Yes, we do that comparative work in public health, but speaking specifically about the Healthy Start program, that is a federally funded program, and there are other districts in the state that have actually applied for Healthy Start funding, but unfortunately they were not funded. So we have down in the Waycross area some work that's being done similar to what Healthy Start is doing to try to address infant mortality rates there.
Well, it's definitely very impressive reduction in infant mortality. Applaud your work. And now we will hear from Dr. Janice Carson.
Well, good morning. You have heard some excellent stories about public health work at the local level, and my responsibility at this time is to try to give you a brief overview, a broad overview of the work of public health, the people that are engaged in this work, as well as the outcomes, some of them that we have with our public health work. Every day, public health practitioners are engaged in public health work, and that work is very broad and very multifaceted. And our ultimate goal is to protect and promote and improve the health of all Georgians. Now, because this work is so broad and multifaceted, we all recognize that we can't do it alone, and that's exactly what you have heard today, that it requires partnerships at the local level, partnerships between the local community and our local boards of health, partnerships between those local boards of health and the state, as well as partnerships between the state and our federal government. And we understand that those critical partnerships are what are necessary so that we can have successful public health outcomes. So I've spoken about the fact that we have public health at varying levels in the state of Georgia, and each one of those levels has a role to play. At the state level, we see that one of our roles is to set policy and to provide programmatic guidance and oversight. And we also define deliverables for the initiatives that our master agreement identifies for those local boards of health. And that master agreement you've heard alluded to is the contract that we have between the state and the local boards of health for programs and services. At the local level, we recognize that that's where programs are actually implemented, because we don't do that at the state level. And that service delivery is guided at the local level by that local board of health, which is by law responsible for that. In addition to that guidance, the local boards of health are required to provide services that are identified in the official code of Georgia, as well as those master agreement services. And because of that oversight by the local Board of Health, you will see across the state similar programs that will have different faces and different looks. I put up there an example. In 2 counties within our state, there was a recognition of a need for a federally qualified health center, in Gwinnett County as well as in Liberty County. In the Liberty County area, there was a local nonprofit organization that had the necessary infrastructure so that they could rally the support around them and actually get approval for their federally qualified health center. And recently, they were given $500,000 in seed money by the state to get that FQHC up and running. Now, up in the Gwinnett district, there had been community support for an FQHC, and they had submitted an application, in fact, several applications for the FQHC, but none of them were ever approved. So the local Board of Health felt that it would, because of the need in that community, it was critical that they move forward in trying to apply for that federal funding. And they have subsequently done that and are waiting for approval of their FQHC application. So in one community, you see that there is a community agency that pulled everyone together and they were successful. In the other community, you see that the local Board of Health stepped in when the community work didn't achieve success, and they have now applied for that funding. And you will see examples of that all across the state. Local boards of health being attuned to the needs in the local community and taking the steps necessary to assure that public health services and health care services are provided. Now, we talk about the work of public health, and we have many, many facets to that work. Ultimately, as I said, our work is to prevent, protect, and improve health throughout the state. Prevention and health promotion programming is key. That's the beginning of the process. If we can stop disease before it occurs, then we're all much better off. And in order to help us with our prevention and health promotion work, we take a look at data that helps us target the necessary prevention and health promotions programs. And I provided for you some examples of the programs that we have here in the state, such as our Tobacco Quit Line, our Nutrition and Physical Activity Plan, our cancer screening, as well as our Live Healthy Georgia campaign that this year we rolled out to 6 cities across the state. Now, the undergirding of public health work is really our surveillance. And each of you is involved in surveillance of a sort because you are legislators and you want to keep your pulse on your community that you're serving. And that is exactly what public health work does in our surveillance. We are keeping our pulse on the community, the state of Georgia. We conduct our surveillance work in many different ways, and it's not just that we collect the data. It is critical that we take a look at the data, analyzing it, and from that analysis we develop interventions, and then from those interventions we do an evaluation piece so that we can assure that our interventions are actually helping us achieve the outcomes that we desire. I provided you with some of the examples of our surveillance systems that we have in place. And with each of those systems, we either have data that comes to us through local surveys of citizens, or we have information that is submitted to us directly from our community partners. And as stated before, at the state level, we analyze that data, and then we share those results with our local partners so that they can do planning to improve the primary care delivery at the local level. Much of our surveillance work and with the surveillance tools that were previously identified on that slide is funded through the CDC, and the CDC also provides us with definitions for that surveillance process. Now we do surveillance work of other types. The state mandates, for instance, that certain communicable diseases are reported to us. And those diseases, then, when they are reported, are cataloged in our state electronic notifiable disease surveillance system, or better known as SENS. Input is sent to the SENS system on a daily basis, and it helps us identify, then, outbreaks of disease. And you heard the example this morning of Arby's and how over a period of time we had input into our SENS system, and as we evaluated that input, we came to recognize that there was indeed something going on in that community. Once we identify disease, then we have local and state and sometimes federal partners that help us conduct the investigation so that we can determine and as well as confirm the cause of disease. And then we work together to implement interventions that will prevent further spread of disease. Now, a few months ago, you might remember the 3 cases of botulism that reported up to a hospital in Washington County. When we did our investigative work in that case, we found that that disease was caused by consumption of a commercial carrot juice product. And as a result of that work, we worked together with the Georgia Department of Agriculture and the FDA so that we could remove that product from store shelves. That disease or that contamination didn't just affect individuals in Georgia. We know that there are individuals in Florida as well as Canada that were affected. So our work helped to make sure that we can ensure the safety of others across the nation and across nations. And lastly, we have a surveillance system that helps us track our progress in some of our health promotional efforts. You've heard it mentioned that we have had a folic acid campaign, and that campaign encourages our pregnant women to increase their folic acid intake so that they won't end up with birth defects in their children. And when we take a look at the information that we find in that reporting system, we can track whether or not the incidence of those birth defects has actually declined. Now, another significant portion of our work, and you've heard examples of this all morning, is our bridge building or our linkages to assure access to care. And we've spent quite a bit of time talking about the linkage between the Department of Public Health and the Georgia chapter of the American Academy of Pediatrics. And it was made mention that DPH provides the vaccine through the Vaccines for Children program. In addition to the vaccine that is provided through federal funding, Georgia puts an additional $6 million into that program to assure that we have sufficient vaccine for our un- and underinsured so that we can have coverage of vaccine-preventable diseases. Someone asked the question about prenatal care. And there was a time in public health where we were providing prenatal care at our local health departments. But we have come to understand that it is more efficient for us to refer those women who come to our family planning clinics and have positive pregnancy tests to refer them to local community providers. And as was previously stated, we have other programs such as Healthy Start so that we can provide that additional support to those pregnant women. So when you mention that we have communities where there are not hospitals that are providing OB care and that your citizens have to travel outside of their community, if there is that support within the community by way of the perinatal case managers so that they can recognize signs and symptoms of problems with their pregnancy and have that support structure in place, then I think that right now is the answer for us. Public health can work together with local hospitals and other providers to try to assure that we can provide those services that are needed. But we recognize that we are not hospitals and we cannot force them to take on a service that they have chosen not to provide. Also in our rural areas, you'll see that in many circumstances we don't have specialists that can provide the kind of specialty care that some of our patients need. And as a result of that, in some of our rural communities, we actually have a telemedicine system. And that telemedicine system connects our local providers in the rural community with experts in larger communities, thereby it increases their ability to deliver the same quality of care at the rural level. The last example that I wanted to mention about our partnerships and linkages is the newborn screening program. And here we link our hospitals who are obtaining the newborn screening sample with our laboratories who are testing the sample, and then we have a contracted provider that actually does the follow-up to ensure that the families and the physicians are informed about the positive screening test and about any early intervention activities that they can be engaged in. You've heard about numerous other collaboratives that we have across the state to address specific local needs, and that is just the work that public health is engaged in all the time, building bridges, building linkages. Now, pardon me?
And we've got 5 more minutes.
Okay.
So I know if you want to
Sum it up.
Yes,
okay.
We have to hear from one other speaker.
Right. Public health is also engaged in regulatory and safety work to improve and protect the health of its citizens. You have examples there of the work that we do. You've heard examples about our emergency preparedness and response work. You have also heard examples about our policy and legislation development work and our rulemaking. We count on each of you to support us when we come up with rules or laws that need to be implemented to improve the public's health. You've approved our newborn screening and our lead hazard reduction laws, and then you see other regulations that we make that go through our DHR board. Part of our work also at the state level involves us being the bridge between our federal funders and our local providers. We receive block grant funds as well as other federal funds, and we at the state then provide administrative oversight of those funds and the programs that they support. We also write grants, as you've heard, not just at the state level, but at the local level as well, to help support needed public health work. And then here we mention all of our hands-on service that is delivered at the local level. And earlier the question had been asked about tuberculosis. We provide directly observed therapy for those clients that have active TB, as well as those who have been screened and are positive for TB. These are the public health practitioners who do the work. We have professionals, including physicians, dentists, and nurses. And we in public health have to compete with the private sector for these competent staff. And here's a list of all the partners that we work with, and this is not an exhaustive list. Just to let you know that the state base is 24% of our total budget, with federal dollars comprising 62%, and then the rest is made up with those categories that you see there. And finally, just to mention a few of our outcomes, you've heard about our immunization coverage rate. And just so that you know, one vaccine alone, the MMR against measles, mumps, and rubella, that saves $16.34 in direct medical costs for every dollar spent. With our folic acid campaign, for each baby that is born without a defect, we save over $400,000 in lifetime treatment cost. Our directly observed therapy that we provided last year to over 500 positive TB patients prevented the spread of TB to an untold number of citizens that came in contact with those individuals. You've heard about our work in the food serving establishments. We conducted over 61,000 inspections. We know that those restaurants served millions of individuals, and of those millions that were served, we had 357 that became ill during 83 foodborne illness outbreaks. We are hoping that our new rules and the training that staff will receive with those new rules will help us improve those statistics. And lastly, just to show you how much we work together collaboratively with our acute care hospitals, there was recently held a 3-day statewide pandemic influenza exercise. We had 85% participation of acute care hospitals across the state, and this was the first of its kind exercise in the nation here in Georgia. So in summary, I just wanted you all to be aware that every day public health works to prevent disease, injury, and disability. Every day we promote healthy behaviors. Every day we protect and improve the health and the safety for all Georgians.
I suppose I have a couple of quick questions. I know you mentioned TB. Do you know what areas of the state there's been a rise in, where we see TB and increase in?
I cannot personally tell you that information, but I can get an answer for you.
That'd be great. And how did the 3-day statewide pan flu exercise go?
It was my understanding from Dr. O'Neill that it went very well.
So Dr. O'Neill's a part of that?
Yes, he is.
Great. We'll hear about that this afternoon then. And we have one other speaker, but if you could, I hate to cut you short, but we ran a little bit late here. So, but Dr. Rosemary Parks, do you want to go ahead and speak briefly? Or?
Sure. Well, this is what I get for being right before lunch. I'll try to go as fast as I can. I'm from the Waycross District, and just to give you a little bit of a perspective about the area that I'm talking about, we're the home of the Okefenokee Swamp. We are the home of Vidalia onions. We're the blueberry capital of the world in Alma and Bacon County. We're a 16-county district, approximately 8,800 square miles in area. We're roughly the size of the state of Massachusetts. And our population is around 340,000, counties ranging from about 10,000 population to 60,000. Our funding, when we look at, in my district, the funding that we have, approximately 30% of it comes from local funding. Approximately 40% is fee generated. And with the recent change in Medicaid at the state, this is certainly threatened. And then 30% of it comes from the state, which is primarily our grant and aid. So certainly with our limited funding sources, any potential changes that occur in any one of those could certainly have devastating consequences regarding what we do so well. Now, there's some challenges in rural Georgia. I'll just briefly mention them. One was mentioned previously, certainly limited providers. In many of my counties, there are no primary care providers. Certainly, prenatal care was brought up. We do have a Healthy Start program. It's Perinatal Health Partners and Best Babies in my district. I will share with you, though, that this is a problem, that these are primarily grant-funded and grant-supported, because these grants end in 2 or 3 years. And part of what we have to prove is our sustainability. And with this particular program, what happened with us, we attempted to negotiate with the care management organizations. We had outcomes that could show that we took women from roughly an average of 30 weeks gestation and made them full term at 36 to 37 weeks. They, however, were not interested in negotiating with us, so we were unable to secure any fees, any money from the CMOs in order to continue the program. So we have continued it, however, recognizing that the grant money is going to run out and still concerns about sustainability. And that is certainly an excellent program that helps provide care. Again, as previously mentioned, in less than half of my counties do we even have a birthing hospital. We have no pediatric subspecialties in my district at all. We do have a really good telemedicine program, as Dr. Carson had mentioned, where we're able to link these children with limited transportation and access to subspecialists in various areas throughout the state. And certainly the reality is for many of these children, they would actually go probably without treatment. Another problem is limited resources even within our communities. We do have a high level of poverty. Many times our public health staff, for example, in many of our counties, we have no animal control agent. So it's our district or our county environmentalists that are involved many times in animal investigations and nuisance complaints. With this in mind, as was previously mentioned multiple times, there are opportunity for partnership, and in rural Georgia, this is a necessity. Emergency preparedness, we've been involved in community pandemic influenza planning committees. We were the leaders in starting these. This involves multiple partners throughout the community, everything from law enforcement to the schools, local government, media, faith-based communities. We've performed multiple drills to test our capabilities for vaccination in the event of pandemic influenza, as well as administration for mass prophylaxis. We partner with the schools, providing immunizations, participating in their wellness program planning. We partner with Georgia Southern University, which is also in my district, looking towards assuring grant funding, brainstorming, and collaborating to determine the needs within the district. We also partner with local businesses and organizations. We have some programs, Local Boys and Girls Club, where we provide health education to at-risk youth. Lastly, we partner with the medical community, and I'll just share this with you. When I first came to this job, I attended one of the local medical society meetings, and I was very impressed by the fact that every doctor there told me that they could not do their job without public health, that we were integral in them being able to do what they needed to do. For the OBGYNs, we provided the nutrition counseling for the gestational diabetic patients so that they could control their blood sugars and have improved birth outcomes. The programs like SHAP, our Stroke and Heart Attack Prevention Program, where we're able to help get these clients medications. And we actually have, in some instances, better control rates than even the private sector. We provide HIV care. Our wellness centers in my district are the only providers of HIV care. So without us, these clients would more than likely go without any care at all. Now, we are seen as the health resource in the communities that I serve. We are certainly promoting and protecting and improving the health of the Georgians in these communities. And I'd just like to share one last thing, and I'll be finished. I do have a quote by former Surgeon General C. Everett Koop, which I think is really food for thought before we break here for lunch. And what he said is, health care is vital to all of us some of the time, but public health is vital to all of us all of the time. And that's certainly the case in Georgia. Thank you.
Thank you so much. We appreciate your testimony. And we will break for lunch, and we'll be back in about 30 minutes. Thank you.
In yesterday's round, kind of around the state, and we had a number of applications go in from existing members for new sites in nearby communities to their current service area. So we're very pleased with that. We've done a lot of work with that, and just kind of as an aside, the state is always, traditionally there's been some help from the state, and we appreciate that very much. We have received in the past some grant dollars from DCH, the Office of Rural Health Services, to allow us to do work with regard to expansion activities. And this has been a big help. We've conducted, I'll back up. If you look at the federal grant process, it's really scary. I mean, it really is. If you take a look at at what the feds put out in terms of what they want in a grant application, there's some schools of thought believe that they make it that way just to scare people away. And I think there may be some truth to that, because it is really a complex type of application. We've tried to make that easier. We've tried to work with local groups. We've provided training. We brought in outside consultants that, as grant writers, to help people to try to make that process more friendly to local groups that are interested, so that they don't walk away from the process simply because they're simply frightened by the process itself. The state funds that we've received in the past have allowed us to do a lot of other work, community development work. This past year, the state provided some seed dollars for Liberty County to develop a fairly qualified health center. That project really, it was impressive what they were able to do. We were talking earlier. I mean, in terms of the work that was done locally within the community, the number of meetings, the number of educational sessions they had with citizens within Liberty County, whether it been Hinesville or some of the other communities, there was a lot of additional work that was done that was good work that, in all honesty, will enhance that application when that application goes into the feds, or it is in now. I believe that application stands a really good chance of being funded in the first submission, simply because of all the work that was done in advance of the submission. And again, the state dollars were a tremendous help there. We've been able to do the same thing in the past. There was some discussion earlier before I got here about the project in Early County. That's our new start. The hospital was very, very supportive there. There was a lot of local support. Again, they were funded in the first round. More often than not, it takes more than one try to get funded. What happens is when you submit that application, there's what they refer to as an objective review process, where an outside group of people, not from Georgia, will review Georgia applications, and they score the applications based on how well your application matches up with the requirements that they're asking, the criteria that they're looking for. Typically, it takes a second or a third try to get funded. What you try to do is learn from what you did the first time. But on occasion, when an application is really good and when a lot of advanced work is done, like in Early County or like in Liberty County, those applications are funded the first time. It shows. The quality shows in that application. So, and again, the support that we've received from the state in the past has been very helpful. We're pleased with, I guess, the current status of FQHCs in Georgia. As I said, we've got a lot of members that all participate in our group. Our association represents all of those organizations. We provide support, we provide technical assistance, we provide training. But we also provide a sounding board for them also to hear what their needs are, and we try to respond to that. So we've seen a lot of growth, a lot of improvement in the whole movement within Georgia in the past 4 or 5 years, and we're optimistic about the future. The one thing that we try to do is build bridges with the state, with other organizations, and we've had a lot of discussions with Dr. Brown's, with Dr. Brown and others within state government, and trying to do what we can do to pick up additional needs in areas. We did have a project, was funded at the same time the Early County project, was one of our existing members in Columbus, Valley Healthcare, worked with the health department in Talbot County. There were some retirements, some staffing things going on there where they felt that they were not going to be, the public health department was not going to be able to continue on, actually partnered with one of our members. The application was submitted, and they were funded the first time they submitted an application for a new site in Talbot County. They're in the process now of getting that site up and running. I believe, again, this is one of those times when an application was funded the first time. I think it was funded the first time it was submitted because of that collaboration, because it did have the support of the community in Talbot. It did have, was able to reference working with state government. Those are the kinds of things that are very important to the whole review process. Again, statistically, you know, if you refer, I don't want to stand here and cite chapter and verse as far as the numbers of people. We're talking about almost a million people served, or a million, you know, visits a year, whatever. We're talking about a movement or a group of people that employ about 1,000 people around the state. That's one of the other booklets. It's the colored booklet that I gave you. One of the other things that we've looked at is to try to take a look at our members, community health centers, as an economic engine within the state. So that particular booklet addresses that. We're in a lot of rural communities. In a lot of areas, we're one of the major employers in those communities. You know, we're talking organizations that employ 30 or 40 people. In some areas, that's big. Obviously, it's not big here in Atlanta. But in a place like Swainsboro or Sandersville or whatever, that's a large number of people to be employing. So there, what we're trying to do is to educate the people that we deal with more about looking beyond the services we provide, but looking at community health centers as economic engines, as part of the Georgia economy. And we feel we are a fairly significant part of that economy. So with that, it kind of gives you, I guess, an idea of what we are, what we do. And again, some of the things that we're trying to do, as I said earlier, is build bridges, you know, with other groups, work with other healthcare organizations. We have a close relationship with the Georgia Rural Health Association. We've got a great working relationship with Charles Owens and the Georgia Office of Rural Health. We've just been able to do a lot with them, and we talk on a regular basis. We work in concert with one another and support one another. And in the needs of rural Georgia, the needs of all of Georgia, even Atlanta, are great in terms of health care, but particularly in the rural areas. There's nothing there. There are no providers. It's tough to recruit providers in those areas. That's one of the focuses that we're working on right now, trying to improve our recruitment efforts where we can recruit a doctor for Sandersville or for Swainsboro. I mentioned Swainsboro because they lost a doctor a year ago, and it took them a year to recruit another doctor. People aren't tripping over their feet to move to rural Georgia. Unfortunately, they're just not. So we try to look at other incentives, other things that we can offer to bring them. Again, another benefit of the support of the state. A few years ago, the state approved our members participating in the state health benefit plan. That was a big. Now we do that at our cost, but we're able to offer a much better health benefit plan to our employees of community health centers, at a much reduced cost. That was a tremendous recruitment tool to recruit, you know, to be able to offer, you know, the comprehensive types of health benefits that the state plan offers. And again, that's what we saw. You know, we saw it not only saving dollars. Collectively, that effort saved about $300,000 among all of our members on health insurance premiums. That money went back into services. But beyond that, it also allowed them to offer an attractive health benefits package to people that they were, you know, trying to recruit. So again, that was something that the state was very helpful with, and we appreciate that also. So with that, I'll, I guess, ask if you have any questions or any comments or about your particular area, community health center, or generally.
Thank you, Madam Chair. I just have a personal habit of looking at statistics and statistical anomalies. And I did notice that while your increase in total medical users were up like 10% over the course of the data that you provided roughly per year, when you look at things like your pregnancy rate as well as your HIV, TB, asthma, they were substantially higher than that. I mean, huge jumps. Are those just statistical anomalies, or are you marketing differently? I mean,
it's more marketing. It's more effort in terms of what we're trying to do.
Because I noticed the elderly users aren't up the same percentage.
No. I mean, now we expect, Because of the Medicare Advantage, the new plans being offered, we expect that these figures will be updated at the end of February. At the end of February, you'll see 2006 figures. We expect to see a change in the elderly. But coming back to the other areas, part of that is simply marketing. We've been trying to do more, to extend ourselves.
How do you go out and find a young pregnant woman?
We work, with, existing organizations in the area. We market. We try to develop contacts within the community that are going to lead those people, to our organization. It varies from area to area.
May I continue, Madam Chair? But I did notice that there was a decrease in the very low birth rate.
That's an anomaly. I can't. We've looked at that.
I mean, if we're looking for potentially at-risk clients,
correct,
and we see an increase in the number of those pregnancies, but we see a decrease in the others, then the natural question is, are we now getting people that perhaps we weren't targeting before, who maybe aren't as much at risk as what our original mission might have been?
Well, we believe we are. We believe we're doing a better job. At that. Again, that's one of the areas that we've tried to focus on with our members, is to get them to understand that, they need to you basically promote their services more within their communities and promote it to the targeted groups that we're doing, and they're doing a better job. 7-8 years ago, a lot of organizations were basically there, but they weren't doing a lot in terms of promoting, and there's been a big change there, so we like to think that it's made a difference. We have more capacity, and I think that's part of this, and this was part of our argument that we made to the managed care organizations. Our members are there. Again, they're able to do a little bit more because of that federal grant, but in terms of the providers they have and whatever, we have more capacity. We can see more patients, and we've done that. A lot of our, with the signing of the contracts with managed care organizations, some of our members have increased their enrollments by 5, 6, some in the urban areas, 5, 6, 7,000 members, whatever, new patients. So all of our members universally, we've polled them, we've discussed it with them, they all have more capacity. They can see more patients. So we're interested in working with other organizations.
Thank you, Madam Chairman. Dwayne, electronic medical records in the healthcare community is something that's being pushed at the national level and everywhere else. And you guys are sort of on the forefront of that as an association. Can you tell me how that project is coming?
It's coming well. We were approved last year, for an amount to help us promote that or move that project along. There was some delays getting the contract, in place, whatever, but the contract is finally in place. So we still moved ahead regardless of that, in the planning. We've been working on electronic medical records for about 2 years now. Our members all have an automated or computerized practice management system, a billing system. So what we were looking at was an integrated EMR practice management system, okay, expanding practice management to include EMR. We went through a rigorous process looking at different vendors, working with our members. We're in the process right now. We've identified, as part of that contract, we've identified 8 of our current members that are ready to move ahead, and we're working with those members. We actually have 3 members. As of a week ago, we have 3 members that are up and running, that are actually using their EMR product in their practices. And according to the deliverables in the contract, I believe all of them will be up, and the 8 that we've identified will be up and running by the end of March. But what we're doing there is we're taking a centralized approach, where they're all tied into a centralized server. They can have a different software package. Right now, our members are using one of 3 software packages, for the combined EMR practice management system. We're not telling them that you have to use X or Y or whatever. It's up to them to choose. We then, load that software package on a central server, and that provides backup for them. It provides redundancy for them in case there's a problem. One of the challenges, and we made this point when we were talking to you all last year, the big challenge that we have with regard to EMR is telecommunications or connectivity out in the rural areas. It's not as stable as it is here. EMR, unlike practice management, if your practice management system is down, it simply means you can't bill for a day or 2 days, whatever. But EMR is a real-time product. You're standing there with a device like this or a notebook, and if it goes down, and I'm the physician and you're the patient, you're just kind of standing there, whatever. I mean, it's got to be working all the time. If it does go down, it's got to come back up right away. So the system that we've designed is again, we've got the backup that's built into that, and that's something that's made our clinical people very satisfied. Now, that reminds me, the other aspect is that we've worked very closely with the clinical people. That EMR is a clinical kind of decision. You're the doctor. You tell me what you want, what you need, and that's what we've tried to do to respond to their particular needs. But we're well underway with that project. We've made a lot of progress. We're, as I said, we've got 3 organizations are actually running right now, and the other 5 will be up and running by the end of March. And we're going to chip away at the rest of them over the next year and a half.
So when the system is fully implemented, if a patient in the North Georgia mountains, it moves there from the coast, that center will have access to all that.
Yes, everyone, they all. And again, the difference is simply how we tie them, how we connect them, whatever. Okay. Again, because of the rural challenges.
I have a quick question. If you could, I'm looking at your proposed, through 206 and all that. You've got, down in Colquitt County, down in the southernmost part of the state, there's several areas that aren't even going to be addressed in the future. What determines the area where you will go?
Well, where
centers are opened.
Things get outdated real quickly. We've actually had some discussions down in that particular area just within the past 3 or 4 months. That map was prepared, I want to say 6 or 7 months ago. It hasn't been updated, but we've had a lot of discussions down in that bottom part of the state just recently. So and again, part of that is that we're out there, beating the bushes, so to speak, talking to. One of the things that I do as I'm traveling around, or whatever, is to talk to people in different communities to try to stimulate some interest or whatever, and occasionally just bumping into somebody in the street kind of works, okay? And that's we're doing it any way we can, trying to stimulate interest and trying to get people to work with us. We're there, and I think what makes that a lot easier for people to accept that is that we're there to help them, we're there to support them, and that's I think that's important.
Okay. Well, thank you so much. We definitely appreciate what you do for the state. I thought it was important for us to hear from organizations providing health care in areas of the state other than through public health. So
thank you.
Definitely appreciate your partnership with them also.
Thank you.
Thank you. And next we will hear from Russ Lapari with, thank you, with Charity Care in Georgia.
Good afternoon. Thank you very much for having me, Madam Chairman, members of the committee. My name is Russ Lapari. I am the Interim Executive Director for the Georgia Free Clinic Network. The Georgia Free Clinic Network is an organization formed approximately 3 years ago by a physician and a pastor in Morrow, Georgia, that started a free clinic and realized the need for clinics in our state to come together and have a collaborative support system. After starting a clinic, they realized quickly that they wanted to go out and find the association to help give them all the benchmarks and needed resources to form their clinic, and there wasn't one, so they created it. Several years later, the organization has done a little bit better. We're on our feet and up and running. We actually hired a full-time permanent executive director that will start in January, which we're very, very excited about. A little bit of an overview of the free clinics in our state. There's approximately 64 clinics, 30 of which are truly free. The other 34 are sliding fee scale or ask for some type of a donation or other financial assistance. It may be $2, it may be $10, and it's as much of a philosophical approach that they want people to participate in their health care delivery, which we think there's nothing wrong with that. We certainly feel that meets the mission of our organization. Free clinics in our state are estimated to see somewhere around the neighborhood of 90,000 uninsured, under and uninsured Georgians each year. It's a pretty significant number. To put that in some type of a perspective for you, that's the combined population of Georgia's 18 smallest counties, all of them, everyone that lives there. So we feel that the clinics are making a pretty significant contribution, both in numbers of people that they're seeing, as well as the financial support that they're contributing to communities throughout our state. The state auditor, and I provided in there as part of the fiscal note to House Bill 1272, estimates that the impact of the clinics is somewhere between $200 to $400 million worth of charity care given each year. We think that's a pretty incredible number. In fact, we do think it's a little bit higher than that. In fact, there was one, just anecdotally, one case study that was done in Gainesville with the Good News Clinic. It's actually one of the larger clinics. They have about 10,000 patients per year, unduplicated, 30,000 patients each year total. And they track 36 people, just 36 people for 6 months. And the answer to this question was emergency room. And they asked those 36 people, if you didn't come here, where else would you have gone? And they said, my local emergency room. So they worked with their local hospital in Gainesville, and they found out that the cost savings for those 36 people for half a year was $400,000 to that local emergency room. So when you take into account that 90,000 people are seen in an unduplicated sense, as best as our estimate can get at this point, it's a pretty significant impact that these free clinics are having. Currently, the clinics receive no state support or federal support. These are not federally qualified health centers. Most of them, they're in varying capacities and varying levels throughout our state. Some are as small as a church basement every third Thursday with a pastor and a physician that open up their facility to see the under and uninsured of their community. Some of them are larger. As I mentioned, I think Gainesville is probably our largest free clinic, and they have about a $4 million a year operating budget. They have a wonderful relationship with the hospital in their community. They also have a wonderful relationship with volunteer physicians. They probably have, in Gainesville alone, about 125 volunteer physicians and then other clinical and non-clinical volunteer staff. So we think that the clinics in our state are poised to make a pretty dramatic impact on the healthcare delivery system of our state for the under and uninsured. We appreciate you inviting us to be part of today's hearings, and happy to answer any questions about the network, about the work that the clinics are providing currently. I know Representative Chanel actually was kind enough to be at our annual meeting this year as one of our keynote speakers, and I very much appreciate that. We think that these clinics are really doing great things, and they're in a lot of our communities. It's certainly somewhat a shame that they're not in more communities, but I think that one of the missions of the Free Clinic Network in the future will be to expand those opportunities.
Thank you. Any questions?
Briefly, if you don't mind, Madam Chair, how do you decide who gets a free clinic?
How do we decide? I'm sorry, I don't.
How do you decide where it goes?
We don't, actually. We're just the association. Communities oftentimes come together to put clinics on. I think there's a bit of a maturation process within the clinics. Oftentimes it'll start with an identified community need, and it will start with, oftentimes they are faith-based, with a pastor and a physician, and then every third Thursday, then all of a sudden it's overwhelmed and ask another physician. Then it grows and grows until the Gainesville, I think, is probably, and I'll go back to that as an example, it's probably a dozen years old. They started with one physician.
Does the association actually go out into communities and based on need and look to see if they can build a relationship, or is it primarily when asked then we intervene?
To date, we have not been proactive in starting clinics. That's something that I think that we hope to do in the future.
Thank you.
Thank you. Appreciate what work you're doing for the state.
Thank you very much.
Okay. Now we have Representative Clay Cox. There he is. He's going to share with us about the pandemic flu preparedness. Thank you so much for coming today.
No, I'm not going to share with you the pandemic flu. I'll just,
please don't.
At least I hope not.
Well, Dr. Brown's sitting by himself. He's sitting today.
Good to see y'all. Thanks for having me, Madam Chair and fellow members. Look forward to seeing y'all in Athens soon as well. Spending some time with you. We're not talking about pandemic flu and something as dire as this, but I have been chairing the study committee on pandemic preparedness, and of course we have focused on, in a large part, public health, and specifically various scenarios on preparing for and responding to the what-ifs relative to the current avian influenza that is spreading across the globe, unfortunately. And fortunately, so far, just within bird populations. And I'll be very quick because I have sit where Donna's sitting now for 3 meetings now, and I'll get right to the chase as I know you want me to. But just quick background, if you looked into this issue at all, there's a lot of information out there. A lot of it is conflicting information. We paraded a number of doctors and experts, scientists, and so on in front of our committee, and we got a lot of varied opinions on this particular current strain of influenza, whether or not it's the big one, if so, when is it coming, how is it going to spread, what extent is it human to human already, and those opinions varied. There were some consensus among the experts. Without question, there is consensus that there is going to be a flu pandemic again. It's just a matter of time. I think everyone that we talk with agrees on that. We've had in history, we've had one about every 100 years, and really that's just indisputable. The most recent one, of course, was the Spanish flu in 1918, and it killed more folks in 6 months than, or in 18 months, than all wars in human history prior to it becoming a pandemic in 1918. So you're talking about something very, very serious, and essentially what they call it a pandemic, they being whoever, the World Health Organization, whomever you want to, your expert du jour, essentially it's a pandemic when about 30% of the population is infected. And in the Spanish flu, 12.5% of those infected perished. So what's so scary about the current avian flu, the current bird flu that everyone's talking about, is the death rate among humans is about 50%. So although few have gotten the virus, half of them are dying when they do get it. Public health-wise, we talked a lot about that and had some of the same folks come through that I'm sure y'all have seen. And just in a nutshell, public health is not prepared for a pandemic in Georgia. But nobody, folks, is prepared for a pandemic in Georgia or anywhere else. A pandemic is really the greatest of all human disasters, more so than anything we can come up with, wars or anything we've ever done to ourselves. It's really quite troubling. Some challenges for public health in getting ready for a pandemic here in Georgia. I even made notes. Donna, you'll be excited. There's, and you probably have gone through this, but yet there's obviously a tremendous nursing shortage in the public health system here in Georgia. We believe they're down about 16% of what they should be based on our hearings. They lost 215 nurses in 2005, another 18 in 2006 so far. I don't think there's any disputing, in my view anyway, that the reason for that is we're just simply not paying our public health nurses enough money. They can make around $33,000 just for an LPN in the marketplace in Georgia, and we're paying them less than $20,000 to be a public health nurse here in Georgia, and we're losing them continuously in Georgia. Got about 1,570 nurses right now in the public health system, 1,579 public health nurses. Now imagine, if you will, if pandemic flu did show up, and it was human-to-human pandemic flu in Georgia in the first 6 months, we believe 4 to 6 months, we're going to have 3 million sick people from this virus. 3 million. Instantly, we probably would need at least 23,000 people to survive by use of ventilators, and we have less than 1,000 available in Georgia right now. We believe in the first 4 months, and when I say we believe, the committee, taking essentially the low, rosiest figures that we have from all of our experts we've talked to, you're looking at probably 57,000 deaths in the first 4 months of pandemic. And if the 12.5% rate of the 1918 flu holds true, and not the 50% rate we've seen so far with H5N1 avian flu, about 375,000 Georgians are going to be fatal cases. So we got some real deficits in public health. we're going to need, for example, we got about 16,000 hospital beds available right now in Georgia. And if in a pandemic situation, we need 300,000. And we need them in 120 to 180 days. The good news is that once these things occur, one of the final consensus was that we can develop and will develop a vaccine. But it takes about 6 months to do that. One of the conclusions that I have come up with, and I believe the committee will share as far as public health goes, is that we need to distribute our resources in a more practical way to deal with human-to-human public health emergencies like bird flu pandemic. For example, I just believe that the money ought to be spent where the people are. Because when bird flu is spread human to human, folks they're not symptomatic for 3 to 4 days. You don't know they're sick. And so quarantining people really isn't an option. This isn't something you can lock people away and they won't spread it and we can stop it. I may be sick right now and give it to 2 or 3 people is what the World Health Organization estimates before I'm actually symptomatic and confined to a hospital or my home. So the potential tragic outcome is that we are not putting our resources essentially where the people are in public health to deal with treating the sick folks and keeping them from infecting as few people as possible. One of the folks who testified in our committee was Dr. Grattan Woodson, who we've read many books, but this is a very good book on, and I felt not so much a doom and gloom, but a more practical manual on kind of what to expect. And just a little excerpt from here. In 1918, the population of the world was 1.6 billion. Today it's approaching 7 billion people. And back then, only 17% of the world's population lived in cities in 1918. Of course, we're very different now. Today, half of humanity lives in urban areas, and the urban areas only occupy about 3% of the world's surface, actual land mass. And so this high density is going to be, we don't really know, but he writes here clearly the human species never has faced a major pandemic with such a large or geographically concentrated population. And so just for the very fact that we are not all farmers, but we're all piled together, makes the potential for pandemic flu or any pandemic much more deadly than anything we've seen in the past. Things that we've done in Georgia on the public health side are just to get ready, and things that we can do. Spend money where the people are, deal with our nursing shortage in public health, and I would encourage not only increasing pace, we can compete with the private sector, but think about increasing our public health staff in our existing locations and perhaps even some newer locations, and looking at the funding formula so that those newer locations might be where the people are. Portable hospitals. These are really incredible things that we talked about, relatively cheap for about $175,000. These things essentially blow up like the moonwalks you see at festivals, much larger obviously, but they're basically a full functioning emergency hospital, essentially a public health MASH unit. Doesn't have the dragon head or the tail on the back or anything like that, but a terrific way to deal with just the emergency need of bed space and treatment as well. I think it's important to consider funding in public health to distribute a manual. This guy also wrote a manual, and he offers it free on his webpage, but just how to treat severe flu, and certainly cover pandemic flu in the home, so that folks know what to do with their sick folks. Because remember, while we're talking about thousands and thousands of deaths, we're also talking about many more thousands of people simply suffering and making it through, and how to keep them from spreading it to folks and getting through with the least amount of suffering possible. There is also some consensus that, well, I'll talk about real quickly just the vaccine issue. We've all heard about Tamiflu. This is one of the most curious things we learned in the committee. There's very little consensus among the experts whether or not Tamiflu will even work, or whether or not any current vaccine is even a good investment at all. And then if it is, who's going to decide who gets it? Because while there are millions, almost 3 million, apparently vaccines available, a stockpile of the federal government right now, obviously there's a lot more than, there may be 3 million legislators, I don't know, in the United States. So clearly they're taken up. So, but the vaccines, do they work? Will they work? There aren't enough of them. Is it a good investment when we're not sure they're going to work at all? Generally, it's thought that's the best opportunity we have, so we ought to go ahead and do it. Right now, you may be aware that Georgia has obtained 1.2 million courses of flu vaccine that is thought to possibly be to offer some kind of treatment for avian influenza. And we have an opportunity to buy another 910,000 courses of the same vaccine for $15 million. And we're working on whether or not to recommend that or not, but stockpiling vaccine has been done, and it can continue with some additional investment. I'm just not personally comfortable enough to say we ought to do it, and that no one can tell me that it even will probably work. It might work. So I don't know if that's spending money on might. I'm just not quite there yet. And then stockpiling over-the-counter drugs. Most folks agree that this is a good thing to do, especially at public health centers, because, and we talked about, the NyQuils and the Advils and just things that you go out and buy when your kids are sick and you're sick at the drugstore. Treating those symptoms, even in a bird flu scenario, is a good idea. And maybe that there's such a run on them that it might be a good idea for public health centers to have a good supply of those, and not only at their current clinics, but also at sites that they identify as places where folks can go to pick those kinds of things up and distribute in a way that's doesn't cause a public disturbance. So, and that's really it. Then the third thing, or the last thing, there's some good things going on here in our state. University of Georgia and some folks there are already working on sort of shifting the paradigm and coming up with treatments that actually improve our cells' defenses to flu viruses and all viruses. So investment in not just public health, but in treatment and in research for developing ways to make our cells tougher. And that's the best layman term. We had about 4 hours of these people come in who are, I'm just glad they're around, but what room they come out of, I do not know. But they're some of the smartest people I've ever heard talking about, when we talk about flu H5N1, H and, of course, N stand for pieces of the virus. These guys are developing, and gals, are developing ways to prevent the H's from doing their job, which is essentially entering and destroying human cells. So there are people out there, state government, private sector, that are working very, very hard to get us ready, but they need our assistance, and that's where I am right now on it. Glad to answer questions.
Thank you so much. Any questions from any members?
Just real briefly, I know the last of the only fatality, the most recent, has been kind of moving west a little bit, and I want to say I'm going from memory, so I apologize. Middle East, somewhere, Turkey. Have we seen any more movement into Europe or anything like that in terms of death and the avian flu?
Not human death. As far as it comes, is the Middle East, essentially.
Thank you.
I know you mentioned earlier about, we've moved now to be in a more urban society. Do you know what percentage of the state population lives in metro Atlanta?
No, do you?
About half. Okay.
Is it
That's
about
about
50%?
right. So, well, I definitely appreciate your work, and I know it ties in with what we're discussing on this committee, and look forward to continue hearing your final report, too.
Same here.
Great.
Look forward to y'all's.
Appreciate your help. Thank you so much, Representative Cox.
You bet.
Okay, we have a final presenter, Renee Morgan, with the Trauma System Study Committee. And hopefully you'll discuss the 3-day training scenario. Someone spoke of it earlier? The pandemic, didn't we? No. The hospital exercise. Thank you.
Well, that will actually come up under emergency preparedness and the pandemic flu. Mine's more trauma specific.
Okay.
Thank you for the opportunity to speak, and I will, on a direct note, thank Representative Schnell for serving on this committee. They were given the task through the last legislative session to look at our trauma system. We know that we lack a trauma system in Georgia, but they were given the task of seeing what we could do to fund an appropriate trauma system. Two of the sheets that you have in front of you list the designated trauma centers that we have in Georgia. It was in the folder packet. There should be a little map. Oh, I'm sorry. There's a little map and a list of our designated trauma centers. And if you'll look at the map right off the bat, you can notice that there's a gap in the center of the state from the lower part. And that shows that there are no designated trauma centers in those areas. There are hospitals that give trauma care, but there are no designated centers. The difference between a primary care facility and a trauma center is that those facilities have chosen voluntarily to take part in a system that improved the quality of care that they give to the trauma patients. In regard to trauma patients, you normally think of the golden hour. Well, for some areas in South Georgia, that's the golden 5 hours. It's just reality. An inclusive system looks at the whole compass of care from the time that the ambulance picks them up until the time they're delivered to a hospital, maybe a second hospital. They may bypass another one or go to another facility to begin with to get that primary care and then be transferred somewhere else. So in some cases, we're looking at 24 to 72 hours sometimes for a patient to get to an appropriate facility that can handle their critical needs. And that's a problem that we all face. And I speak on a personal note because I've been a licensed paramedic in the state of Georgia for 27 years. So I know how it is to ride around in the back of an ambulance and not be able to take your patient where they need to go. But this committee looked at several aspects. They, to begin with, they had 4 separate meetings, and 2 of the primary meetings to begin with was just a brief history of the trauma system, where we were, what our problems were, where we needed to go. But they were given primarily the task of looking at funding solutions. Some of the things that we've been able to identify is that we have approximately $230 million of uncompensated trauma care just from our hospitals each year. Those hospitals are functioning at the bare minimum. They're losing a lot of physicians. They're losing a lot of nurses. It's very difficult to keep those hospitals functioning. At present, we have probably 4 of the hospitals on your list that we've been in recent negotiations in the last month in regard to them dropping their designation altogether, just because of the financial aspect. What we have come up with as far as funding sources has been to look at extra fees, perhaps on cell phones, the ad valorem tax, on car tags. I know that any type of tax is an ugly word when you start talking to the voters, but it is a situation that we need to look at seriously. The other thing that we've looked at is the super speeder fines, which, since motor vehicle crashes are a primary cause of the injuries, that seems the most logical place to start looking. Also, what we've done with this is have went to a lot of our primary stakeholders, our EMS community, Georgia Hospital Association, our Association of County Commissioners has been involved in a lot of the meetings and discussions, the ER physicians, Medical Association of Georgia, our trauma surgeons. So we have talked to a lot of our representatives around the state, and we've come to a consensus that we hope to be able to raise through these fees approximately $80 million a year. That's just in projections from other states that have been presented to us. So we have no data to confirm that. That's just what we've been able to identify. And as far as the inclusive system would also allow for extensive injury prevention. We understand we need to prevent those injuries before they happen. That was one of the reasons for tacking on to the super speeder fines. If we can control the speed, maybe we can control the crashes. The other thing, too, is the involvement with the emergency preparedness as sort of a close and to give you an idea that we feel that if we can be prepared for patients on a daily basis, that we can be prepared for patients on a critical basis. So it's very difficult to give you the whole encompass of the trauma system in just a few minutes, but I'll be happy to answer questions.
Questions of the committee members? Yes, Representative Stevens.
Thank you. Last year, whenever we were given a map similar to this one, it was, I'm number 23. We were told that there was a possibility that the medical center in Macon may drop its level 1 trauma status, just a possibility, which would have left the entire I-75 corridor without a trauma system.
That is correct. They have still not completely given up the idea of dropping their designation. They were actually sort of the spearheads behind a lot of this discussion that's come up through the Trauma Study Committee, because they saw the urgent need and they were not willing to give it up without a fight. But the problem is the coverage of physicians in the state. We have the subspecialties and the trauma surgeons are at a critical level for shortage. We have some areas where there's no neurosurgical coverage. A lot of the hospitals, that's the reason for the diversion issues that we have in Metro Atlanta, is some of the Metro Atlanta facilities may only have 2 or 3 neurosurgeons. If both of them are tied up or one's in surgery and one's on call, they have to divert.
If I may, Madam Chairman. Further, I guess I'm a little concerned that now that we're moving towards a funding mechanism, is there been any discussions about a certificate of need for different levels of hospital and where they might be strategically placed?
That has been briefly discussed. We have identified some hospitals just based on the area that they're located, specific to major population areas and where we're seeing more injuries. But we have not come to that specific conclusion as to how that would be determined. Right now, the process is strictly voluntary. The hospitals that we do have get a minimum amount of funding from the state, strictly for trauma registry process. It's $740,000 that was a budget allocation that started about 2 years ago, and it's divided between the 15 centers based on their level. So you can imagine the level 1 only gets approximately $70,000 a year. But it's to provide us with data. And that is one of the good things that Georgia has done. And since the data was implemented, we are one of the few states that have all of our trauma centers utilizing the same database, which is the trauma registry from the American College of Surgeons. For the first time last year, Georgia contributed to the National Trauma Data Bank. So we do have some good things going in our favor. But there is a need for more hospitals.
Yeah, I'd like to piggyback on that a little bit. I'm really new on this, but when I see, what is that, Floyd County and Whitfield?
Yes.
And I see others, there's a part of me that thinks, why aren't we centrally located? Give me the history a little bit on how we decided that we ought to put 2 in Northeast Georgia.
Well, again, these are voluntary.
Okay.
These hospitals, the trauma system started basically back in the late 70s or early 80s. Federal money came down to the states under Title 12, and it was determined that basically what happened in the state was probably around 19 to 22 centers wanted to join into the system, and they were essentially blessed as a trauma center. For quite a period of time, we had ups and downs with hospitals coming in and out of the system, and then around 1999 or 2000, we had sort of a restructuring in the state of our trauma program. We went in and reevaluated the existing centers that we had. We lost a couple during that process because they had essentially been non-existent as participating in the system. They had not contributed to the registry program or participated in the organizing of a statewide system. So we were left with these hospitals basically that you see. A lot of hospitals that are in the areas where you don't see marks are really good at giving trauma care, but they're not doing it in an organized system, and we receive no data. 70% of our patients go to non-trauma centers, and we have no idea of how those patients are filtered through the system, which hospitals they may have gone to first. We hope to do something to entice the other centers to come in, but honestly, the small pot that we have for the registry program, once you actually have more hospitals coming in, that pot gets smaller because that 740 is dispersed between those existing centers.
And if you're in a situation like Representative Chanel was talking about earlier, like hospital, then you just get primary care and then are diverted to someplace else?
That's correct. In a lot of cases, it falls on the shoulders of the pre-hospital community, because what they will do is they recognize that their facility does not have, for instance, neuro coverage and a head injury, and they will bypass the local facility to go to a level 1. They are given in most areas that recommendation to do so by their medical director. But there are a lot of cases where that doesn't happen. They go to a local hospital, and knowing they don't have a neurosurgeon there, they will be held there for a couple of hours and sort of examined and x-rayed, and then it will be determined that they need to go to a higher level of care. But in most cases, that golden hour has passed significantly, and especially for brain injury patients, you've gotten into a major crisis with those because you've crossed over that line of when they can get that immediate care.
One more, if I may.
Okay.
And there's a neurosurgeon, or lack of them, in southwest Georgia, and we may get sent up to Columbus. I just want to make sure I understand. Do we have someone sitting at a local hospital somewhere that's making a decision that says that this particular head trauma patient may or may not be worthy of being diverted someplace else? Is someone making that call?
Primarily, again, it falls on the protocols based on your pre-hospital personnel.
Are those protocols, did they change from hospital to hospital? Or?
The protocols are standard within each service, but each service's medical director and hospital medical director can override any protocols they see fit. We can make recommendations from the state on standardized protocol, but the local medical director overrides those protocols.
Would that medical director then have to have some kind of training in?
We hope.
Neurosurgery to be able to recognize if it's a good transfer or not?
Well, that's one of the reasons for the designation process, because those hospitals that are involved in the designation process, those physicians and surgeons are held at a higher standard. They are required to have certain levels of education and training to be able to assess the trauma patient and determine if they can be treated there or to be transferred somewhere else.
In your opinion, have you seen more or less or no real difference in potential medical liability because of the way that system is set up versus states that maybe have a better system in place? Or, I mean, and if you don't feel like you're qualified to answer, that's fine too.
Well, I think that the public is still not quite as involved in the trauma system as they should be, because I believe the public's perception is that any emergency room can take care of any need they have. And so that's part of our goal, is to educate the public through the designated trauma centers that we have, because as a requirement for them to be designated, they have a strict injury prevention profile they have to follow. So through the education, we hope to educate the public that there are appropriate. And the other thing, one of our other speakers had brought up earlier, was the appropriateness of the use of the emergency room. Because if we can take the load of the clinical patients off of the major trauma centers, then hopefully we can open them up to the trauma center patients.
Thank you.
Thank you.
Thank you, Madam Chairman. Just very briefly, this committee, and it's a joint House-Senate committee, by the way, it's met 4 times. We're going to meet one more time to come up with recommendations. Representative Rogers, and kind of in answer to one of your questions or observations, that as Renee correctly pointed out, in Georgia, this is a voluntary deal altogether, and some states don't have a trauma network at all. Some, and we heard from, for example, Texas, it almost effectively is mandatory that every hospital in Texas be a trauma. I mean, they tie it into reimbursement otherwise. And so it's all over the board, but in Georgia, effectively, what you get if you volunteer is an opportunity to lose more money. You know, I mean, that's because of the requirements of being these different levels. A real issue so far is that it is an education thing. I certainly do not know. I'm not chairman or anything else. I'm just a member of the committee. But I don't think that there's been. I don't think the general public. This is not as big an issue with the general public as it really needs to be. I mean, coming up with $70-80 million, and I don't know that would do it, but that's going to be tough. And when the general public demands that happen, then it probably will. But it is a major issue in this state. We've looked and heard so many numbers, Renee, but what is it? Something like 600 or 700 needless deaths or something like that every year. Versus us having a proper trauma thing in service. That's a lot of folks, and it's folks we know. It's our constituents and maybe some of our neighbors and family members that wind up being part of those statistics. So it is something that we need to stay, that needs to stay on everybody's radar screen. We certainly, I don't think we'll be able to quote unquote solve that with one study committee report, but it's something that is extremely important and something that we've got to figure out a way to deal with.
History, tells us in most states that have an effective trauma system and that is adequately funded through multiple disciplines or state funding or however it's funded, is generally taking a major impact. And I hate to bring this up, but generally it's been someone high-ranking in the governor's office or lieutenant governor that's been injured to cause focus to come to trauma. That's allowed state funding to do that. That's what happened in Mississippi. They have a huge funding for trauma systems, but it took, I believe, their governor to actually enter into the trauma system before the funding came available. But we're not, in an attempt to seek funding, we're not looking at solving the problem. We know that's impossible. We're hoping just to shore up a little bit of what we have, and hopefully not to lose any more physicians. It is a public health issue. If we lose more emergency physicians and trauma physicians, the hospitals are all going to be in jeopardy. So it does affect public health. Plus, if we can get those injured patients to the right place in the right time, it puts them back in productive activity and life sooner. We've proven that. We can show statistics to show that already. Thank you.
Appreciate you coming and sharing with us today. Now, do we have any members of the committee have questions for anyone else, the previous speaker today? Do you want to talk with them personally? Yeah. That'd be great. I just want to say thank you to the committee members. Thank you for coming today. We have a daunting task. Public health is vitally important to this state. And I think we've seen what a great job the Public Health Department is doing, especially in rural areas right now. And I think, we definitely don't want to necessarily impact that. But I think next couple of meetings, what we'll definitely be looking at is the funding formula and also the shortage of public health nurses. And we'll be hearing from maybe some of the Metro County Public Health Departments and some of the areas, their challenges that they have. We definitely are be cautiously looking at this. I know a lot of people are very concerned, but we just want to ensure that all citizens of Georgia are receiving the public health facility, treatment they need. So, but thank you to each one of you, especially those who came from Waycross and Early County and Valdosta. So I know it's a long ride, especially to be here early in the morning. Representative Chanel?
Madam Chairman, would you remind at least me on the committee when our next meeting?
December the 18th. Will we be in this room, do we know?
Yes.
This room. We'll start at 10 o'clock that day also. And we'll be, like I said, looking at the current funding formula and begin looking at proposed changes. So thank you so much.